the first ever approved ACR education partner. Brought to you by the Emirates Rheumatology Academy. This activity is included in the ACR's Education Partner Program. Don't miss the chance to attend the best rheumatology hybrid meeting in 2021. Meet our top-notch expert speakers: Dan Baruch, Gerd Burmester, John J. Cush, Megan E. Klaus, Doric Erkin, Laura Gossick, Arthur Kavanaugh, Peter Nash, Christopher Richland, Philip Seo, Joseph Smolin, and Richard M. Silver. They will present hot topics selected from the best of ACR Convergence 2020. Benefit from free registration. For more information, visit our website at www.era-rheumatology.org. See you all there!
Arthur Kamishta, who recently retired, was a professor consultant physician and director of the Lupus Research Laboratory at St. Thomas Hospital, London. He studied medicine in Barcelona and internal medicine in Madrid, Spain, where he developed an interest in connective tissue diseases and received his PhD. He was awarded the MRCP in 1999 and FRCP in 2002. He joined the lupus unit in London 30 years ago and has been instrumental in developing it into an internationally recognized tertiary centre receiving referrals from all over the UK. He took sabbatical leave, May 2015 to April 2019, setting up lupus services at Dubai Hospital, United Arab Emirates. In January 2020 he joined GSK as Global Medical Expert, Lupus, for China and emerging markets. Professor Kamishta has a strong research interest in lupus and connective tissue diseases, with a special interest in pregnancy and antiphospholipid syndrome. He has published extensively in lupus, Hughes syndrome, and related areas with more than 700 original papers. Dr. Kamishta, the floor is yours.
Thank you very much for the introduction and welcome to this GSK sponsor symposium. And let me remind you, this is a non-CME session because it's promotional. The title of my lecture today is On a Path Towards New Targets in SLE, Low Disease Activity and Remission. Just to my conflict of interest again. I am full-time employee by GSK since January 2020. This is what low disease activity and remission we're going to discuss today, and the objective of the program: to review the treat to target recommendation in SLE very quickly, then review the concept of low disease activity and remission, how we define them, and understand the long-term outcomes in SLE associated with low disease activity and remission. And at the end, I'm going to show you a couple of slides about the new indication with pediatric lupus, because we did that small trial showing efficacy in pediatric lupus above the age of 5 with Benlysta. This is the problem that we face with lupus, that patients with lupus frequently have remission and flare, and during the flare period, obviously, we need to treat, because if you allow for the disease to continue without treatment, that would lead to damage. And our first line of treatment, usually glucocorticosteroids, and both disease activity and persistently giving the patient corticosteroids, both of them lead in the long term to damage accrual, and damage lead to more damage and obviously to premature death. It has been estimated that up to 80% of late damage occur in lupus is due to glucocorticosteroids, and this is why we are keen to really reduce steroids to the minimum dose possible, to the shorter duration time possible. This is an interesting study following up patients for 25 years, and you see that up to 50% of patients with SLE experience organ damage within the first 5 years. And that's very important. And this is not only due to disease activity, in part also due to treatment, and mainly steroids. If you look carefully about the treat to target and the recommendation by the EULAR of 2019, you see clearly that achieving lowest possible disease activity remission, which is unfortunately not that frequently we achieve that in lupus, but they are accepting now the expert and the recommendation in treat to target that low disease activity, perhaps the target we should aim for, because this is achievable. And there is data to suggest that achieving this, it's associated with better outcome. So lupus low disease activity state is a composite index. And as you can see, one of the definitions, there are several definitions. One of the definitions which has been used frequently in the literature is suggesting SLEDAI 2K less than 4, without major organ activity and no hemolytic anemia or gastrointestinal activity, no new disease activity compared to previous visits, and physician global assessment with a scale 0 to 3 has to be 1 or below. And this while receiving the patient prednisolone less than 7.5 milligrams daily and well-tolerated maintenance doses of immunosuppressive drugs and biologic agents. This is the low disease activity, which is accepted by most experts in the field, and some variation of this has been applied as well. The most important thing to see whether achieving low disease activity in lupus is really prevent from organ damage. And as you can see in the slide, patients who experience more time in low disease activity have relatively lower rates of organ damage. And that's important because not only the idea behind it, but that to prove that achieving this has better prognosis and better outcome. This is an Italian study showing that achieving low disease activity for 2 years or more significantly reduced the risk of damage progression over 7 years of follow-up. Again, persuasive evidence that achieving low disease activity have reduced the damage accrual over time, which is important because, as I mentioned before, damage leads to more damage, and more damage leads to premature mortality. So it's important. Now, I am a member of the DORIS group, and this is an international group dedicated really to accept and maybe design protocols or definitions, what we understand by remission, what we understand by remission of therapy, and what I understand by remission on therapy. And hopefully these definitions in the future will be used in clinical trials as well. So we accepted finally in the last meeting that remission should be defined as SLEDAI 0 or BLAG 2004 DNE and ICLAM 0. Why we included ICLAM is important because ICLAM is the only score that you retrospectively you can apply. If you are going to do retrospective study, ICLAM is the only score you can apply retrospectively. The other scores has not been validated to be used retrospectively. How we define remission of therapy? Those require patient to be on no other than SLE than antimalarials. So not allowed steroids or immunosuppressive drugs. How we define remission on therapy? Stable maintenance antimalarials, low dose steroids less than 5, and maintenance immunosuppressive drug and biologics. So remission of therapy, and remission on therapy. 3 definite, defined definitions of each of them. Again, it's important when we apply these definitions, patients who experience remission on treatment have relatively lower rates of organ damage. So again, by applying this definition by Doris, we showed that patients who experience remission on treatment have relatively lower rates of damage. And again, the same study from Italy showing a remission lasting 2 years or more, consecutive years, reduced the risk of organ damage progression. So again, is persuasive way of showing the studies, long-term follow-up studies, that achieving low disease activity and remission on treatment have very good prognosis and very little accrual of organ damage over 7 years of follow-up. So low disease activity and remission as potential new therapeutic targets accepted by the EULAR recommendations, and up to 50% of patients with SLE experience irreversible organ damage within 5 years of diagnosis. This is very important, and we need to maximize our efforts trying to prevent or slow the progression to organ damage. All we accept that irreversible organ damage is driven by disease activity, flares, and long-term glucocorticosteroids. So by monitoring disease activity, by controlling disease activity and flares or preventing flares, and especially minimizing the use of long-term corticosteroids is likely to prevent long-term organ damage, which is irreversible. We accept now that low disease activity and remission are treatment outcomes aligned with treat to target and SLE guidelines. As I mentioned before, they are associated with reduction in the risk and progression of organ damage and reduction in cumulative glucocorticosteroids use. So these concepts is important to apply in our daily clinical practice and not only for clinical trials. So that's important concept or change of attitude that trying to achieve a low disease activity ideally will be remission, if possible without steroids, but if not possible with a minimal dose of steroids possible. Always remember hydroxychloroquine is a useful drug, cheap drug to keep in the long term, and even remission without therapy is considered antimalarial as benign drug and should be given in the long term, providing you check the eyes of these patients in a regular basis. Once they reach 5 years of use, there is evidence that using the drug for less than 5 years very unlikely to cause retinal toxicity. So let me now move a little bit to Belumimab and long-term organ damage. Once you participate in clinical trial, like our BLISS 52 and BLISS 76, all participants are invited to take the drug in the long term. And this is essential in studies sponsored by the industry, because that in this case, that will allow you to gather data about safety. And most importantly, in the case of lupus, you will gather data about organ damage, because it's very difficult in a randomized controlled trial for 1 year duration to assess damage. You need a long-term follow-up. So in our long-term extension studies of BLISS 52 and BLISS 76, the pivotal studies that we did to license Belumimab for use of lupus, you see interestingly that 85% of the patient, there is no increase of organ damage after 5 years of follow-up. Even those who started at baseline with some organ damage, there is limited increase in organ damage. It looked like that by giving Belumimab in the long term, you might slow progression to organ damage. Obviously, you can criticize this kind of study. This is, you say, this is an open label extension study, and you don't have a comparator to compare with. We overcome this problem by going to Professor Urowitz in Toronto, is a famous expert in lupus, all his life worked in lupus. And we asked Professor Urowitz, by using propensity score, trying to match 100 patients from our long-term exposure to Belumimab to another 100 patients from his cohort who were treated with standard of care without taking Belumimab. It's not any matching, it's a propensity score, trying to match as much as possible patient and controls. And interesting, you can see in the results, summary of the results, that the SDI scores at year 5 was significantly lower in the Belumimab treated group compared to the Toronto group, 61% less likely to progress to a higher slick damage index score compared to the Toronto group, and the proportion of SDI increases 2 or more was statistically significantly lower in the Belumimab treated group compared to the Toronto cohort, which is treated with standard of care without Belumimab. This is giving us the hint, although it's not ideal randomized control study, but there is the only way to prove that Belumimab might slow progression of organ damage in the long term. As I promised, in the end, I would like to finish with a couple of minutes telling you about a study that we completed about a couple of years ago using the Belumimab in the pediatric population above the age of 5. It is a 2B study. Obviously, pediatric lupus is very rare. Fortunately, it's not that frequent. And it took us 5 years to do this study, small study, with about 93 patients. And it is 2B, is not the idea is to have statistical analysis or anything other than exploring that trend to see whether Belumimab added to standard of care in pediatric population give you a better response than standard of care alone. And most importantly, to see the pharmacokinetics of the drug, to see whether 10 milligram per kilo that we give in the adult, as you know, in the adult population, it's safe and effective in the pediatric population. As you can see in the end of the study, we ended up with only 93 lupus patients in the pediatric age above the age of 5. The majority of patients have disease activity around 10. The small number of patients have between the age of 5 to 11 because lupus is typically is of the disease above the age of 12 after the first period of these young girls. Usually the disease starts. From the age of 5 to 11 is not that frequent to find patients, and this is why the small number of patients. The majority of patients in the study were between the age of 12 and 17. As you can see, we cannot apply statistic, only we applied numerical differences. And in orange, you see the patient treated with Belumimab, and a black patient treated with standard of care. And you see the SRI response was better for Belumimab treated group compared to standard of care, 52.8 versus 43.6. And when you split the SRI response into the Selena SLEDAI, into BILAG, and no worsening in physician global assessment, all of these 3 parameters were in favor of Belumimab. Looking at summary of the results of the whole study that we did, at week 52, the response rate was generally consistent with those observed in the adult intravenous Belumimab population. A higher proportion of Belumimab subjects were Printo responders compared to placebo. Subjects on Belumimab had a 62% lower risk of experiencing a severe flare compared to the placebo group. Overall, no new safety concerns were identified relative to the known safety profile of intravenous Belumimab in adult SLE. The overall observed Belumimab exposure were consistent with observed in adults, i.e. the intravenous formulation at 10 milligrams per kilo is valid as well for the children. And all results, I emphasize again, should be interpreted with caution due to the small sample size, and we couldn't apply really statistical analysis. And my final slide is the indication has been changed in some countries in the region. My understanding is in United Arab Emirates and Qatar already changed to allow to use the drug in lupus patients with active disease, especially with positive high double-stranded DNA and low complement not responding to the standard of care. And the dose recommended is day 0, day 14, day 28 as induction, and then for the follow-up every 28 days in the long term. As I mentioned now, the same dose is going to be used in children as well. Thank you very much, and I would be happy to take any question from you if there is any question from the audience. We still have about 7-8 minutes. Thank you. Showing you prevent severe flares, you prevent disease activity, and the data that I show you today and in previous occasion as well, you might slow progression of organ damage. And this is very important. These are three aspects in the long term that are extremely important. Regarding COVID, okay, everybody is concerned about COVID. Should I take Pfizer vaccine? Should I take Moderna vaccine? Should I take the Chinese vaccine, the Russian vaccines? The answer is nobody knows. We don't have experience in lupus in the long term to say which one is safe. Okay, so as GSK, we cannot say take the Chinese or take Pfizer or take, it's not. But the most important thing, we think vaccination is important in lupus patients, and COVID is not going to be exception. Which vaccine should be is not clear. Which is safer? It's you know mRNA is a new form of technology, not only for lupus patients, for lupus patient and for you and for me. We don't have lupus. Still, we don't know the long-term outcome. But I think vaccination is important in general and should be taken by our patients. And I don't know if there is more questions there. What's the best DMARD with Benlysta in lupus nephritis and about safety of such combination? We did a trial in lupus nephritis, you are aware, and this trial was successful and published in New England Journal of Medicine in September. So that we tried Belumimab added to standard of care, and as you know, standard of care is either cyclophosphamide, the European regime, or mycophenolate mofetil. In our trial, only 25% of the patients were treated with cyclophosphamide and 75% of the patients were treated with mycophenolate mofetil. And it shows, although both of them are effective, but it was superior, slightly superior, maybe mycophenolate mofetil in the treatment of lupus nephritis added to Binomial. There is another question. Is there any data about Binomial for neuropsychiatric lupus in pediatric SLE? No. The answer is no. In both BLISS, in all program, in BLISS 52, BLISS 76, Northeast Asia study, subcut that we did studies, and lupus nephritis and pediatric lupus. Unfortunately, underline unfortunately, we excluded patients with severe active CNS lupus. And the reason for that is very difficult to assess. There is many syndromes. There's not only one disease. It goes from epilepsy to cognitive disorder to headaches. It's very difficult to assess. And in all our study, we decided to exclude these patients. Only very few number of patients were treated with Belumimab outside of clinical trial, and very difficult to know. And then our recommendation is not to use in severe active CNS lupus. Athir, do you have anything more to add?
No, there is a debate between us. It's about, do we need to miss a dose of Belumimab to give vaccination? Would that improve the immune response somehow, or it doesn't matter?
Well, that's good. That's good question. If you decide to do that, no harm. I can tell you no harm if you miss one dose, but there is no evidence you should do that. We think, based on other vaccines that we assessed the effect of Belumimab, there is no evidence that Belumimab diminish the response to the vaccine. If you want to do it, that's fine. I don't think it's wrong. You want the half-life of Belumimab, fortunately, is 19.5 days. So if you miss one dose, that's fine with me, if you would like to be precautious. But in theory, you don't need to do that. Thank you. It's a very practical question. Thank you, Athir. I appreciate that. Thank you. If there's no more questions, wish you all the best for this meeting, and I look forward to hear some of the lectures. Okay?
Thank you very much.
Take care. Thank you very much.
Good afternoon, ladies and gentlemen in UAE, and good morning everywhere. I have the pleasure to host or moderate the Janssen Symposia, and we are inviting Professor Eduardo Meisler, who is known to many of us, but just to reiterate, he is medical director and medical research organization, principal investigator in many of the trials, phase 1, 2, 3, 4, the clinical protocols, designer to the public and private medical institution. He is a club bio member, advisor and teaching in biosimilar in Latin America, instructor of medicine, New York University, many awards and publications. Really, I cannot summarize everything here. He's one of the instrumental people around the world. Just need to remind people that symposium event is not part of the CME accreditation, just for your notice. And thank you very much, Professor Meisler, for accepting the invitation, and the stage is yours.
Thank you very much, Admiral. It's always a pleasure to be at least virtual. Inshallah, this year, at the end of the year or next year, we'll be able to join again and to have these great meetings that we used to have, and these great dinners that we both of us sit together and talk about life and families and all that. So this is sponsored symposium by Janssen, by the opinions that I'm going to bring here are my personal opinions, and clearly this is something that we've been working for a long time. And some of you have heard me start talking about this, but I think we need to work more and more on this. These are my conflicts of interest, and I have designed and worked for many different companies. As you know, I work in a university, but I design clinical trials for all private and public companies. The treatment of rheumatoid arthritis have dramatically changed in the last years. Inflammation in RA was often difficult to control, but then many of the medications that we use now came into the market. Methotrexate was optimized, developed reliable instruments to assess and to treat, early diagnosis 2010 criteria, adoption of treat to target in 2011, and the introduction of biological DMARDs and target synthetic DMARDs dramatically changed. So now we know that our patients who are coming to the clinic are less severe, but also that we need to achieve remission. And remission, it is clear in the treat to target, and it's also in all the guidelines. And I put here the old guidelines of 2016, but I have been in the 2016, I have been in the 2020, and all these guidelines are bringing together the recommendation that we need to bring remission, but also we are starting more and more to discuss sustained remission, not only to achieve remission, but sustained remission. But the first question that comes to my mind is, what do we mean when we assess remission, and why is that so important? Because if you look at the course of rheumatoid arthritis and disability, the natural course goes together with disability. Even if you treat late, disability goes very high, and structural damage is clearly a part of it. If you treat early, it's better, but the ideal course will be to have a flat line and to continue to have patients and a perfect path to control the disease. So you have seen this slide multiple times, the update of 2014 of the treat to target with the idea of remission and low, or if you cannot achieve remission, low disease activity, and then the idea of sustained remission. So treat to target, but again, sustained remission. And the primary target of treat to target was the ability to sustain remission. And that has been proven, and I'm bringing you an old trial on the purpose that 2013, this trial monitored and actually brought to life the idea that treat to target in early rheumatoid arthritis, but also their trials in late, one of them published very recently by the Dutch group, her name, we'll remember in a second, from this girl from Portugal who moved to the Netherlands, Ramiro, Sofia Ramiro, to remember names, that have proven that early and late rheumatoid arthritis can be treated with treat-to-target. The benefits are dramatic. And again, this is the first cohort, and you see clearly treat-to-target improving FAC, improving FF36 if you apply treat-to-target in early. But also, the sharp score dramatically stays very low if you apply treat-to-target comparing to the standard. And you see treat-to-target moving through time. I told you, from 2000 to 2010, look at how much better we have done, how clearly we have improved remission by using treat-to-target, by applying drugs, methotrexate monotherapy, or the combination with TNF. Clearly, you see the combination with TNF better, but all those have really proven that if you not only use these drugs, but you apply treat-to-target and strict and very clear guidelines to how to treat these patients aggressively, they improve. But really, we're looking for deep remission. And in that, EULAR got together with the ACR, and we came up with the decision to create a Boolean remission. What Boolean means, one or less tender, one or less swelling, C-reactive protein of one or less, patient global, and scale from 0 to 10, 1. So let me challenge you, if I put you this is something that I did a long time ago, and I tell you which one of these patients is in remission. So it's patient 3, 4, and 5. It's patient 4. It's another combination. None of the patients are in remission. All of the patients are. Give you 2 seconds. Look at the numbers. Look at the swelling, the tender, the CRP, set rate. And you tell me which one it is. Now, so if you look at DAS28 CRP, patient 1, 4, and 5. But if you do DAS set rate, it's only patient 2. Boolean, it's only patient 4. So all of you are correct, and none of you are correct, which means that we still are in death with a decision of what defines remission. Because what defines remission, it's going to change the way we're going to treat these patients. So if you go for Boolean, it's different if you go for Boolean on the clinical trials, or if you go Boolean for clinical practice, or if you do C-dye, or if you're saying C-reactive protein is too cumbersome and I do C-dye instead of S-dye. So it will depend on individual clinics where you work, will give different results. And you see this beautiful, very nice publication, this paper from 2018, that the ACR Boolean is at the center, but you see that the circles do not overlap. Some patients on DAS will not have S-dye, and some patients with C-dye will not have Boolean. And that's exactly what I show you. But we are aware that goal-oriented strategy was associated with a higher likelihood of achieving remission. So usual care is totally different from goal-oriented. And because of time, because I don't have enough time, I did not bring you the slide of Sofia Ramiro, but you can look at the paper from last year and see how not only early, but also in late array in the cohort, you can reduce dramatically and bring patients into remission. And the likelihood of achieving remission or low disease activity with the first biological demand was 71% higher in the goal-oriented. Now, why this is so important? You know, we are at the COVID time when that's why we are not meeting at this time, why, or any other place in the Gulf. And the reason for that is that there are going to be less resources used in rheumatology or in cardiology or in other specialties because of COVID. And we need to prove that we are cost effective. Cost effective means that if you bring patients into remission, median work disability days is 0. Permanent work disability is 0. If patients do not even achieve ACR 20, permanent work disability is above 50. So we can show to the payers that this is very cost effective. And this also applies if you are in remission to AEQ5D, another way of assessing functionality. So if you are on C-dye remission, your EQ5D, similar to HAC, almost normal. You can see that nobody's normal. I have back pain. If you actually are on high disease activity, you are 50. So achieving in Austria remission brings you to an almost normal SF36, very low disability, and very high work productivity. So you really start losing a lot of days if you are on moderate to high disease. But also the target, and this is a paper published last year in July. This is our two cohorts, Norway cohorts, both of them from Norway, both of them early, and both of them trying to achieve remission. One, the Arctic, and the other one, the Nordic target. The Arctic aiming for DAS of less than 1.6, the Nordic trying to reach 2.6. And you see both of them achieve the primary endpoint. So you're saying, Eduardo, what are you trying to show us? I'm trying to show you that if you aim for less than 1.6, your Boolean remission is significantly higher in the same group of patients than if you aim for less. So the higher you try to achieve, the more significant is the impression that you're trying to bring into the patients, the higher the remission. And this will bring patients, this remission will actually lower the number of surgeries that you require, hip replacement, knee replacement. And if you are on high disease activity, you will have triple or quadruple the number of surgeries than if you are. But for that, you need to be persistent. And how do we define persistence? Persistence is the duration of time from the initiation to discontinuation. And you see that it is in the treatment target. The desired treatment target should be maintained throughout the remaining course of the disease. But it's not really put there. It's on the 8th. It's not so clear. It just remain in the course of the disease. So what we are trying to tell you is that we will try to look into treat to persist. T2P, not only T2T, but T2P. It becomes sort of hard to repeat. Because it will improve the healthcare expenditure. It will improve as patient population gets older, will contain cost, and there will be increasing value, which will make for the payers around the world much more logical to afford all these medicines. But persistence is based on efficacy, safety, on patient's experience, and adherence. Low persistence is a significant problem in chronic diseases. All of them increases cost, increases the disease progression, increases disability, the number of cycling, and Professor Peter Taylor is talking from Oxford all the time, and this issue of increasing the cycling of drugs, because we have a lot of drugs, but not so many. And so clearly, we need to lower the number of cycles. And we need, as I show you, for that, we need adherence. Patients need to adhere to a certain kind of treatment. The non-adherence lower persistence dramatically, as you see. And how do we measure persistence? Easy. We look at when you start, 2 years later, you get 80, and 5 years later, you get 50. And you see here, sustained remission is uncommon in clinical practice in RA patients. In any way you measure, DAS28, SDI, ACR, look at remission. It's hard to sustain after 5, clearly very low. The reasons for that, primary lack of efficacy, secondary loss of efficacy, partial response, adverse events, and affordability. In the Gulf, there are many people who come from different countries, are not fully covered by the government, and many times cannot afford to continue on these drugs. So all these 5 are the causes of discontinuation. And treatment persistence among patients with immune rheumatic diseases have been proven to be cost-effective. This is a trial from Dalling and collaborators from Sweden. And you see patients who are persistent and patients who are non-persistent. And you see a difference in US dollars in the cost because you are non-persistent. And that applies to all the things. But again, You can see here unadjust and adjust treatment, and you see here Golimumab behaving better than other ones. Golimumab against Adalimumab behaving better. Golimumab against Etanercept or Certolizumab. So even in the different TNF, persistence could be dramatically different. And I show you here that persistence is dramatic because it lowers disability and increases the cost. And we did 2 advisory boards, international advisory boards, discussing this. I mean, these were sponsored, these were absolutely free. No company was involved in these advisory boards. And we asked physicians, what do you assess at the time of prescribing a biologic? And I got all different kind of answers. Experts suggest main reasons were comorbidities, diverticulitis, CHF, hepatic disease, administration route, frequency, monotherapy. None of them mentioned persistence. When we asked them, they said, well, infliximab has a lower persistence, but some of us like it, some of us dislike it. Again, persistence was not top of their mind. So we did a systematic literature review that we published very recently. And what you see here is that out of those, tocilizumab came as the highest persistence, followed by golimumab above all of the other TNF. Clearly, remember, tocilizumab here is intravenous and golimumab is Q. So there is an issue when you use intravenous. It's much easier to measure persistence. And you know if patient is not persistent because you can tell the guy when he's not coming to the visit, you have missed 1 or 2 visits. And the same thing here, if you remove the IV, it will be golimumab above all. But what was very interesting, what were actually the predictors of treatment survival? And you have increased survival, combined treatment with methotrexate, and I keep repeating that if the patient can tolerate, we should continue to use methotrexate. Etanercept was better than infliximab or adalimumab. Clearly, second line of treatment was better than the third or fourth. So, first drug you choose is going to be one that it will stay longer. So, persistent is very important, top of your mind. What's lower? High-dose steroids. Guys, we need to start really working. And in my department, we are making the point, not use steroids or use the lowest possible dose for shorter time. And we published that last year. Higher basal disease activity, it is bad. The higher the disease activity, the worse that you will do, and women do much worse. There are many others you can read about. I mean, Symphony, real-world data, you can see the Spanish data, golimumab subcutaneous, 30% patients with RA, 31% with spondyloarthropathy, 30% with PSA, 60% of patients with biological demerit experience, patient concomitant. And you see here how golimumab really did so well. 57.1 patients remained 5 years after on golimumab. Real-world data from Spain. Real-world data from Norway now. Remember what I showed you before. Very high sustained remission, very high persistence of the drug after 5 years. So 60%, around 60%, 57, 62% of patients remaining on the drugs when you actually use golimumab. Now, go beyond when you actually follow persistence of golimumab as a second-line biologic in patients with spondyloarthropathy. 1 year, 2 years, 4 years, probability of persistence 75%. After discontinuation of the first TNF, patients with spondyloarthropathy show a high probability of persistence on golimumab. These are very severe patients who are hard to sustain. The probability of persistence was similar high in patients with axial spondyloarthropathy or psoriatic arthritis, and in patients who discontinue the first TNF due to loss of efficacy or other reasons. Real life effectiveness of golimumab in the second TNF is high and durable in spondyloarthritis. In Finland now, drug survival of TNF in rheumatoid arthritis. Again, look at comparing to certolizumab or infliximab. RA patients treated with each biological DMAR as first, second, or third. Later in Finland, 3 years follow-up. Discontinuation rate at 3 years is lowest compared to the other drug. So again, even comparing other TNFs, so exactly what we found in the systematic review. So these are individual countries, I show you the systematic review. But not only that, I'm going to show you something that we're doing right now in our population. We just presented the 2-year data on 116 patients, with some of them with one type of medical insurance and other patients with history of hypertension, smoking, and diabetes, and Simponi treatment in patients with RA, PSA, and SA. 51 months of follow, we have 60%. Very similar. First year, 80%, and the second year, 65%. Exactly like the international numbers, exactly like the systematic review that we have done. So you have here 2 years, 57%. And why that's so important? Because the rate and risk of myocardial infarctions in RA is much higher. And we are well aware of that. We can discuss the recent publication by Pfizer and the presentation that was presented 2 days ago on the risk of target synthetic DMARDs. But we are well aware that RA by itself increases the risk of myocardial infarction. So you're saying, is that for everybody? No, it has to do with having flares. Very nice paper published in Annals of Rheumatic Disease in 2016. Each acute flare increases the risk by 7%. Intermediate activity continues, also increases the risk. Remission is almost no. So if you can keep your patient on remission, patients will not have what I just showed you, increased risk, and you can lower the risk compared to the general population. Because another very interesting paper published in the Annals 5 years ago. Look at this. DAS28, more than 3.2, 3.2 to 5.1, or more than 5.1. And you see the cumulative survival. If you are in low disease activity, not even remission, the cumulative survival is much higher. And these are the years of disease, which shows you 2 tables. It's much more important to be in continuous remission or continuous low disease activity than the numbers of years. So, not so clear, not so important how many years you have the disease. It's how aggressive you are and how well controlled you are. And the last cardiovascular slide that I'm showing you is, look what happened if you use a TNF. Acceleration, adjusting. If you use an anti-TNF, all of them, compare conventional synthetic DMARDs, you lower your risk of myocardial infarctions by almost 50%. And that was clearly significant. So being aggressive, using anti-tumor necrosis factors, anti-TNFs, any of one of these, and having your patients in remission will lower the main reason of death in your patients, which is cardiovascular. So you will lower disability, lower cardiovascular. So in conclusion, treat to target has dramatically changed the treatment-oriented goal and the outcome of rheumatoid. In conjunction with the guidelines that has allowed us to reach remission for low disease in a significant number of patients. But remission is elusive, and I show you that confusing. And reaching remission once or twice does not prevent morbidity, mortality, and the consequences of prolonged rheumatoid arthritis, as I have shown you with cardiovascular disease. Treat to target only superficially mentions the idea of persistence, and doctors are definitely not aware. I show you two boards, each one with more than 10 key opinion leaders. The concept of treat to persist has been recently introduced by a group of researchers, the idea that treatment should persist in time to be effective and efficacious, as well as knowing which drug to choose for individual patients based on the most suitable outcome. Personalized medicine may allow us to reach and sustain that target. So, treat to target, absolutely. Low dose steroids or no steroids at all, absolutely. And persistent remission, lower disability, and increase the patient's quality of life. And clearly the value, cost, effectiveness is COVID. Thank you very much for your attention, and I'm happy to answer.
Thank you very much, Prof, for this nice presentation. It's a big issues and problems in which policy to select, maybe personal medicine at the end. But even personalized medicine, sometimes we need to be sensible or clear to us what personalized medicine we do. You mentioned two things. One of anti-TNF in particular, they work better for efficacy if they are combined with methotrexate. So if I'm in the clinic, I need to push my patient to take methotrexate, particularly if they are not in total remission. But particularly in Middle East, I don't know in Argentina, but in Middle East, people just whenever they have a blink of improvement, they just stop one medicine and they want to say monotherapy, and that is for them is what we call it adherence or persistence on the medicine, although it's not ideal, optimal. We always face this dilemma: should I push for methotrexate or not push? Any way you do that in
No, you're absolutely right. We all push for methotrexate, and I show you our systematic review showing clearly that to increase survival of drugs, we need to push for methotrexate. So no doubt about that. But you're absolutely right, that people don't want to use methotrexate. But I think we need to differentiate. One thing is, as you pointed out, if you are in remission and I stop methotrexate, one thing is if I start treatment and you are on high disease activity. When you are on high disease activity and I start treatment, very few patients would not want to take what we tell them because they are on pain. Once they are in remission, the same thing that happens to you happens to us. People want to stop medications. They want to stop methotrexate. They want to maybe have one or two drinks, and the issue of methotrexate and alcohol is an issue. So all those reasons are pushing patients to stop methotrexate. In our university, we try to convince people to continue. But if they really don't want, the first rule of the EULAR guidance is share decision with your patient. And I am a strong believer on adherence. So I rather follow their wishes and have a clear and realistic conversation with them. And if they don't want to take, I don't want them to lie to me. And I rather stop methotrexate and see how they do that actually continue methotrexate and think and write on my chart, in my computer nowadays, that they are taking the medication when they're actually not doing it. So a fair conversation with the patient, I think, should go a long way, and I agree with you.
right. Taking as long as no more question, taking the issue of secondary comorbidity, and one of the comorbidity is fibromyalgia. It came to my mind one of the abstract in New Law, I think, but spondyloarthritis, not rheumatoid, about the quite significant difference of retention rate between men and women. We know spondyloarthritis could have fibromyalgic element, perhaps more than rheumatoid, but do you see that is in study terms or in practical terms? You need to give special attention to this gender issue or not?
You're, as always, you are absolutely right. I think fibromyalgia is a major issue, and it's a major issue in the way we assess patients. And you know this, and we have talked through dinners about this. We do DAS28, but a huge part of DAS28 is joint pain and patient pain. What do we do with that with fibromyalgia? And that's the discrepancy that we see. And that's so beautiful about cardiovascular disease, cholesterol. You measure cholesterol, it's a number. Diabetes is a number. So much simpler. In our practice, it's so much difficult. Relies so much on experience. So the more you know about the disease, the more you know about your patient, the better you can qualify the patients. And we have all seen patients, and we see them every day, that they come and you see them and you evaluate and you do a sonogram, no power Doppler, they do great. And you ask them, how do you feel? Oh, 5/10. And I always tell them, I was teaching an epidemiological course 5-7 years ago, and I told my students to go, wish there's no orthopedics in the audience, go to the orthopedic ground rounds. I asked the chairman of orthopedic, who's a friend of mine, and do pass on physicians. So two of my fellows of epidemiology students went and asked them 30 orthopedics before grand rounds fill the form of how much pain they were having that day. And first of all, you were absolutely right. They were off the chart. Some people have 8/10, 9/10, and you wonder how can they perform surgery the whole day. So there is an issue of understanding what visual analog scale is, and the reason of fibromyalgia and the perception of fibromyalgia in women and men. We know there is a discrepancy. So could it be that there is more fibromyalgia in women, and because of that, the ones who have that, they do much worse? It could actually, you are absolutely right. It could easily be that fibromyalgia plays a major role and actually is the major reason why women tend to respond less than men.
We have a couple of questions before we close. We have 3-4 minutes to go. One from Dr. Bezant Al-Nadi, asking, what is the definition of sustained remission?
Great question, because sustained remission could apply to different people. And the paper that I suggested to read, Sofia Ramiro from the Annals, she's pointing to 2 points separated by 4 weeks of that remission. That's sustained. Some other, like us, we will say that at least you need 3 points to actually, during at least 4 months, to have that. But between 2 points and 3 points of remission. But clearly, 1 point of remission means very little.
Very little. And the last question, perhaps, from Dr. Pranab Chaudhary from India. He say, what will be your take on RA patient and TNF for 6 months followed by oral DMARDs? Is that a sensible approach?
I think it's a very fascinating question, which I've been against. I mean, let me just say, because this is a Janssen-sponsored symposium, this is off-label. But I'm a strong believer that from Dr. Huizinga's data of early aggressive treatment, as this doctor from India is saying, if we can treat early aggressive and bring patients into remission, everybody's in remission now. Okay, so now we are in Boolean remission. What happens if you stop TNF right there? Early treatment, early aggressive, we bring patients into remission, then we stop and we see. Many patients may reflare, so those may need forever treatment. But many patients will stay only on methotrexate or even drug-free remission. So I am a strong believer that if I had RA, I will treat myself very aggressive the first 6 months to 1 year. And then if I'm in Boolean remission, I will stop the biologic, and then 1 more year, full remission, to stop the methotrexate.
Thank you very much, Professor Meisler. I think we come to the time for 30. There is one more question, but I think we are just short of time because we have to follow the schedule. I think there is a break about 15-20 minutes, and followed by the program of the best of ACR. And I would like to thank you a lot for explaining a lot of these concepts. And we will see you again in a few minutes. Thank you very much, Prof. Thank you, everyone.
Inshallah.
Yeah,
See you soon.
Ladies and gentlemen, good afternoon. I'm Rita Harifi, and I'm very honored to announce the official start of the ACR Convergence program brought to us by the Emirates Rheumatology Academy. And with no further delay, let me introduce the first speaker, who's going to give us a lecture on, it's actually an overview on biologics in rheumatology, revolution and perspectives. And I'm very happy to introduce Prof. Gerd Burmester. Prof. Burmester is a professor of medicine in the Department of Rheumatology and Clinical Immunology in the Charité University Hospital, Free University, and Humboldt University of Berlin in Germany. Prof. Burmester is the recipient of numerous awards, including the Jan van Bremen Medal of the Dutch Society of Rheumatology and the Karel Nashman Prize for Rheumatology. He serves on several editorial boards, including the Journal of Rheumatology and Clinical Rheumatology, and he is the associate editor of the Annals of Rheumatic Diseases, official journal of EULAR. He's the author himself of more than 800 original and review articles. Prof. Master, the floor is yours.
Okay, so thank you very much, Gita, and thank you very much for the invitation. And it's always a pleasure to talk to my Arabian colleagues and friends. I wish I could be in Dubai and not sit here in a dark room in an overcast with an overcast sky. February is always a bad month in Germany because we are so much longing for the springtime, but still we have to live through a couple of very dark days and cold days. Actually, it's going to be like -11 in 2 or 3 days in Berlin. So please be very happy in your countries that you have nice weather, blue skies, which we are longing for. And thank you very much for the invitation. And when I got the invitation and also the invitation for the ACR Congress, where I presented some of these data, I didn't really know initially how very timely the subject on biologics is, because you also know that the vaccines are also biologics, and therefore it's a pleasure for me to talk about the revolution and perspectives of these important molecules. And here. Okay, these are my disclosures. And let's go back in time. In 1993, which looks like ages ago, but it's not so long ago, only like 22 years ago. And there, the American College of Rheumatology, or the American Rheumatism Association, at that time said, well, rheumatoid arthritis treatment is like a pyramid. It consists of basic anti-inflammatory therapy, and then you may add additional therapies to the foundation. The exact timing and order of added drug is variable. But this pyramid has tumbled down since we have now so good means now to treat rheumatoid arthritis and most other inflammatory rheumatic conditions. And let me show you the time scale here. And you see that I think there were several milestones. One important milestone obviously was the discovery of glucocorticoids in the treatment of rheumatoid arthritis. The next one was the introduction of methotrexate. But then already around the millennium, we get the biologics, and we have now the small molecules, the JAK inhibitors. And I think also very important are the biosimilars, which are, of course, biologics, but they are so much less expensive so that they are these agents are accessible to many, many people in the world now, because obviously the biologics used to be very expensive and the biosimilars are much less expensive and many more people can now get it. And it's amazing. We started with rheumatoid arthritis and Crohn's disease as initial indications. And now you see many, many other indications, most notably also, and we'll hear a very nice talk about this later on by Christopher Richland, right after me, ankylosing spondylitis and psoriatic arthritis and many others are now approved. And well, let's have a look when the first antibody therapy started. And that was actually in 1891. The first antibody was injected into a human being to fight off bacteria. And this had been generated by Emil von Behring together with his Japanese postdoc, Shibazaburo Kitasato. And at that time, the sera, which we now produce in cell cultures, but of course, at that time, they were produced in horses, because each horse gives you about 5 liters of blood. And here you see Emil von Behring and Kitasato in the lab, and you see this was a completely different lab work at that time. You see the guinea pigs running around, and you see the lab note on the bottom of my slide. And the question that he rose in 1890 was, what is this blood able to neutralize the poison that is in patients with diphtheria and also in animals? And he said, yes, it is. And that was the starting point of actually the passive and the antibody development. And at that time, you may want to know that diphtheria was the #1 killer in children at that time. Like we have now in many instances, corona in the older people. At that time, the younger children died of diphtheria, and it was a terrible disease. And you see here a letter written by a mother of all these children to Emil von Behring, because he saved the life of all these children with his new antibodies, the antitoxin as it was called at that time. And that was used in 1891, and you see the vial here. And of course, then it went on, and interestingly, two French researchers, Ericot and Richer, performed already animal experiments using cancer cells in order to generate therapeutic antisera, and it has taken a long time until we now use monoclonal antibodies to fight off cancer. And one instrumental person besides Emil von Behring was Paul Ehrlich, also a Nobel Prize winner, who actually sort of discovered the antibodies in a side chain therapy and said, well, these antibodies, they are like magic bullets to cure many, many diseases. But then he said, well, I'm sorry, we cannot really hope much of this direction of therapy. But he was completely wrong. His depression was not really well founded at that time. And because now they really have advanced, and without these antibodies, modern medicine would not be possible. And then in 1974, Köhler and Milstein generated the first monoclonal antibodies. Then the first therapeutic monoclonal antibody appeared. And as I mentioned, around the millennium, the monoclonal antibodies and the fusion products arrived. So the true revolution are the monoclonal antibodies. And these had been generated and discovered by two researchers who actually were interested in the genetics of immunoglobulin, not so much about diagnostic or treatment. They said, okay, in order to sequence our antibodies and look into subsequently into the genes, we need a lot of material and a lot of homogeneous material. And ideally, it should be monoclonal, derived from one clone. And from the Nobel Prize lecture, you see, how did they do this? They took spleen cells from mice that had been immunized and then fused them to immortal cells in order then to clone out those with the desired specificity and then inject them into mice and take the cells out of them, and then have, with cloning, the monoclonal antibodies in basically unlimited amount. And then the biologics arrived in rheumatology in roughly about the late 80s, but then the golden years started in the 1990s, as you see here with these papers. So not only directed against CD4 molecules, but also against TNF, IL-1, and now many other molecules. We actually started in 1990 using a mouse monoclonal antibody, which was called MAX-H5, and injected it into patients with desperate rheumatoid arthritis, where we had no other means. And the antibody had been donated by Frank Emmerich at that time. And you see here that with this particular monoclonal antibody, we were quite successful, because obviously many of these anti-CD4 antibodies, which for many reasons are no longer used nowadays because it's a little bit more complicated, had different properties. And also chimeric antibodies were used by Gerd Riedmüller and Ferry Bredfeld, also with initially good success rates, but then the randomized control trial showed that, well, indeed, these antibodies were not very successful, not different from placebo. So luckily, serendipity happened, which, as you see here, means something that you discover and you had not what you had not aimed for, like Christopher Columbus wanting to go to India, but by serendipity, he discovered America. So initially, Infliximab had been developed in etanercept to fight off sepsis. Adalimumab was generated to fight off graft versus host disease. Rituximab had been developed to treat non-Hodgkin's lymphoma, abatacept for transplantation and psoriasis, and tocilizumab to treat multiple myeloma. And you all know that they are now used for many, many indications and other indications, especially in inflammatory diseases. So here was the sobering trial using a monoclonal antibody against TNF-alpha to fight off sepsis, because there is a lot of TNF in the serum of patients with septicemia, but unfortunately it didn't work. And then it started to be used by especially Tiny Maney, Mark Feldman in London, because they felt that TNF would be a very, very important molecule. And TNF had been discovered by Bruce Beutler along with other colleagues such as, for instance, Anthony Cirami. Bruce Beutler got the Nobel Prize, and he said, well, he called it cachectin, worked to my advantage because there was already an interest in TNF at that time as an anti-neoplastic protein. But he could show that this protein had other properties, especially in inflammation, and then could develop it at the Rockefeller University at that time, and also did more studies subsequently with this. So TNF-alpha apparently is a very important molecule being released, we believe, by macrophages in the rheumatoid synovium, which then is instrumental in activating many cells, destroying cartilage and the joint. And so Sir Mark Feldman and Sir Ravinder Maney, they were knighted because of their discovery, met Jim Woody. And Jim Woody was very depressed. He was from Centocor. They had done all these trials in septicemia, hadn't worked. So Centocor at that time, that had produced the monoclonal antibody against TNF, was really basically a broke company, and the share was only worth $2. Luckily, they met with Mark Feldman, because Jim Woody had been a postdoc in Mark Feldman's lab. And these British researchers said, well, we have found out that TNF might be very important in the rheumatoid synovitis. Why not use that antibody against TNF in treatment? And these slides actually were given to me by Sir Tiny Maney, and they showed these slides show the initial trials. Actually, they started with 20 patients and could show how successful this treatment was in these patients. They show nice videos at that time, or films, of patients who could not climb stairs were able to do so after the treatment with these monoclonal antibodies. And then were joined by Ferry Breitfeld, Jochen Kalden, and Josef Smol and Peter Lipsky in order to further develop these agents. And of course, initially these antibodies had been mouse antibodies. And the mouse, of course, is foreign to the human system. So therefore, you need to modify the molecule and make it at least chimeric, or maybe even fully human, as you see here. And one of the researchers who was instrumental in doing this was Jan Vilcek, who came from the Slovakian country. Actually, his parents had to flee from the communists, and he designed, together with other colleagues, infliximab, which only has a partly immunogen antigen recognition site, but otherwise is human. He got the order by Barack Obama, and this patent has been worth a lot of money. And here, as you see here, Jan Vilcek did pioneering medical research, and he had hidden from the Nazis as a child, escaped the communist regime, and then generated this and gave 105 million to the New University of Medicine, because that had been his professional home for many decades. And also, we are a little bit, I wouldn't say angry, but disappointed that the rheumatologists were not the very first to publish these data. But Sander van Deventer, and it's an interesting story behind it, I don't have time to tell you everything here, but it was actually a neighbor's child who was suffering from Crohn's disease. And they had also been interested in fighting off septicemia, but they still had a little bit left. And then they gave infliximab to a child with Crohn's disease and discovered a remarkable success in treatment in this girl and published it in The Lancet. And then, as you see here, Michael Elliott, together with Tiny Maney, Mark Feldman, did the first publications. Larry Moreland and Michael Weinblatt and Roy Fleischman then worked on the fusion protein called etanercept. Barry Breshnian working on IL-1, and the colleagues from Knoll Company at that time in Germany were generating D2E7, which then was named adalimumab. And also the history of etanercept is quite interesting, because the idea to generate this agent was also, and I didn't know that beforehand, in Germany by the company BASF, and the biochemist said, well, we looked into the urine of patients with fever and characterized it and found 2 TNF inhibitors, and then got the idea to put part of this receptor on an immunoglobulin and to then patent it. And then subsequently, this agent was developed by Immunex, and they had obtained a license of the BASF patent to market Enbrel, or we could say etanercept. And the history of etanercept has been very nicely described by Robert Katz in The Rheumatologist. And also he could point out that it was quite difficult for Immunex at that time to develop this agent, but it was so successful that finally it was marketed by Pfizer and sold to Amgen, and is also one of the most important and most sold product in this area. You see here 2 colleagues who were instrumental in developing it, Larry Moreland. You see here the remarkable data that he produced already in 1997 and followed up by Michael Weinblatt in a subsequent paper in these patients receiving methotrexate plus etanercept at that time. Also, a major breakthrough was the development of this agent in children. And at that time, inflammatory joint diseases in children still are, but at that time they were really terrible. They led to growth retardation, and the children suffered a lot from these diseases. But luckily, the biologics, I think, basically have changed their life, also due to these new products. And here, as an example, 2 colleagues, Daniel Lovell and Barbara Fink, who presented these data also in the New England Journal of Medicine in 2000. And now let's get a little bit into adalimumab, which I believe is maybe the most, in terms of sales, successful drug on earth ever. And how was that developed? It was also the company BASF, as I mentioned, at that time was also called Knoll, and they wanted to develop it, the molecule TNF, to treat cancer. But one colleague, Achim Möller, said, well, let's have a look where we find a lot of TNF in which diseases. And you see here, you see a lot of TNF when you go into the serum already in lupus, rheumatoid arthritis, in kidney rejection and graft versus host disease. And so they asked the question, well, maybe this is an important molecule which we need to neutralize, and attempted to do this initially with an Epstein-Barr virus transformed cells, but then got together with a very famous company, Cambridge Antibody Technology, and jointly then generated the agent adalimumab by technology which is called phage display technology, isolating B cells, amplifying it by PCR and looking into the genes, and then clone it in the phage library. And then you have a column, and then you can isolate the molecule subsequently. So initially, this compound was called ERIC because there were football addicts in the team generating adalimumab, and they named it after the soccer star Eric Daniel Pierre Cantona, who was a very fierce soccer player. Then they called it D2E7, and subsequently it was called adalimumab. As you know, ADA is sort of the first name. Then LIM means inflammation mediator, U is fully human, and MAP means monoclonal antibody. And unlike the other agents that have been published in Lancet or New England Journal of Medicine, this was just a small supplement that characterized the initial data by Joachim Kempeni at that time from Knoll Company. And you know that then the drug was sold to Abbott, which is now AbbVie. And you hear some godfathers, Jochen Saalfeld, one of the developers, and the initial trialists, Rolf Rau and Leo van der Putten. Obviously, it didn't stop there. Other monoclonal antibodies came up. Paul Emery here, in this case, used golimumab also in rheumatoid arthritis. And subsequently, IL-6 became a very interesting target that had been generated by Japanese colleagues, namely Tadamitsu Kishimoto, who had also cloned the IL-6 receptor. IL-6 at that time had several names until the researchers found out that it's basically only one molecule, and with a lot of activities, as you already saw. And here you see the Japanese group in the middle, Tadamitsu Kishimoto, who detected it, and then researchers like Nishimoto and Tom Takeuchi and Yamamoto, who then worked further on this agent. And tocilizumab came out as the winner, and this is not an agent directed against IL-6, but interestingly against the IL-6 receptor. Initially, it was coined to fight off multiple myeloma. It didn't really work, and therefore they thought, well, there's a lot of IL-6 in rheumatoid arthritis. Let's try it there. And actually, one of the first major trials was done by Ernest Choi and Gabriel Panay. And Ernest Choi told me, well, the ethics committee at that time did allow him only one injection or one infusion with this agent. And but you already see on the right-hand side how successful it was. And then other papers came up. And you see here that the Charisma trial, also performed under the leadership of Tiny Maney, showed that this is a very active and helpful compound, because Vismodin showed in another phase 3 trial or a subsequent phase 3 trial that apparently 8 milligrams per kg plus methotrexate was the best approach in rheumatoid arthritis. And now we have one more agent that has been approved in rheumatoid arthritis, sarilumab, and in development, and the phase 3 trial has been very positive, called olokizumab against the ligand. Of course, rheumatoid arthritis is a very important disease, but as you will hear subsequently, also spondyloarthritis is a very important disease to tackle. And here, Jürgen Braun and Jochen Sieper, who are friends of mine working also in Berlin, persuaded someone from the German company at that time, Essex, to give them a little bit of infliximab to do a very limited trial in patients with ankylosing spondylitis. And then they could enhance this because they were very successful and show that this is a drug that works not only in rheumatoid arthritis, but also in ankylosing spondylitis. And as you see here, when you extend this treatment and you transfer patients from the placebo group into active group, that this treatment lasts very long, as shown by Xenophon Barliakos and Desiree van der Heide. And the agent adalimumab could show that it was successful, as could be shown with etanercept and golimumab and certolizumab as well. And then I will not say too much about IL-17, because this will be the subject of the next talk. Is also a very interesting agent to be targeted. And this was shown here in the MEASURE trial, where you see here that secukinumab against IL-17 is also a very successful drug. And I cannot talk too much about the biologics in psoriasis, but as you see here from this picture, also anti-TNF approach and the IL-17 and IL-23 approach is very successful. And you can I wouldn't say cure, but lead all these patients into, most of these patients into remission. Also, co-stimulation modulation is a very important approach using the agent abatacept, which interferes with the activation of T cells by blocking the antigen presenting cell. And another important approach is the action of rituximab. And this was Joe Edwards, who had the idea of killing peripheral and maybe lymph node B cells. Many people thought, well, this is a crazy idea, but he persisted in doing this and was also very successful with this agent. Obviously, and as I mentioned, biosimilars are now very important.
Dr. Meisler, I'm sorry to interrupt you, but we're running out of time, actually. So if you allow 1 minute, and then we'll have to take questions.
Okay. And then I will just go to my final slide. And let's stop here. So biologics are very important despite the advent of the small molecules. They're very specific. They have, luckily, no pharmacologic off-target effect. They're very safe. They have long action. They can be modified. And as you know, they can even be generated against the SARS-CoV-2 antigens. And biosimilars can lead to significant cost savings. And in many indications, there are still no alternatives with small molecules. And I would like to close with a patient of mine who was very successfully treated. Patients could not really walk anymore, but then went to the South Pole and the North Pole, and just due to this modern treatment. And I would like to, with thank you to my mentors, Joachim Kalden and Bob Winchester now at Columbia and at that time Rockefeller, and the Hospital for Joint Disease, to the patients and my many colleagues in Germany. And thank you very much for your attention.
Thank you very much, Prof. Meisler. Thank you, Prof, for this amazing overview. I personally enjoyed very much listening to the history of the immunomodulators that we're using routinely now, and it's always exciting and interesting to remember where we came from a decade and a half ago. And if we don't have any questions from the audience, I have a little question before we move to the next lecture. Since your lecture is entitled Revolution in Perspectives, what are the perspectives of immunomodulation in the near future? And I would like to ask you specifically about the dual targeting. What do you think about the dual targeting in rheumatoid arthritis, for example? Do you see, and I know that in psoriatic arthritis, for example, we have an anti-TNF IL-17 inhibitor at the same time. What do you think about it, and in terms of efficacy, but also especially in terms of tolerance?
I think we have learned a lot also from the cancer field, where these new bispecific antibodies are extremely important. I think we obviously we are in a different population regarding safety, and that's the major concern. If with a bispecific antibody you hit two molecules, that you also run into safety problems. But I think it's still just the beginning that we learn from our friends in the cancer research, that it might be very important to tackle two molecules at the same time. So far, I mean, it has been done with anti-TNF and anti-IL-17, which gave a little bit of success, but it was not really a breakthrough. But I think if you find the right combination, it will be very successful. The nice thing about these biologics is that they do not have off-target effects. They don't interfere with the cytokine system. You can generate them very quickly, as we have learned with the SARS-CoV-2 spike protein, where we now have monoclonal antibodies that are already used in moderate cases and to the fight off the corona. So I think despite these new molecules, biologics will have a very bright future.
Thank you. So we continue talking about cytokine targets. but we'll move more specifically to psoriatic arthritis in a very exciting lecture given by Prof. Christopher Richling. Prof. Christopher Richling is a professor of medicine and chief of allergy, immunology, and rheumatology at the University of Rochester Medical Center in New York. He's a member of the ACR Division Directors Special Committee, and he also directs the monitoring of junior investigators in the GRAPPA, and he has published over 160 manuscripts on topics related to psoriatic arthritis, lymphatic mechanisms of joint flare, and bone remodeling. Prof. Richling, please.
Thank you. It's really a pleasure to speak at this meeting. I had the opportunity, as Gerd said, would love to be there in person. I was very fortunate in 2018 to travel to Dubai and speak at the combined Society of Emirates Rheumatology and American College of Rheumatology meeting, and it was really a great experience to be able to interact with the folks that were there, and I hope to do it again someday. So I want to speak to you today about cytokine targets and psoriatic arthritis, and I'll mention a little bit about spondyloarthropathy. During this presentation at the ACR, the other half of this was presented by Georg Ehrman on SPA. So this is more focused on PSA, but I'll bring SPA in as well. And the idea here is to talk about insights from clinical trials and to go over some of the basic science elements underlying the IL-17 and 23 axis, which is a really exciting area in biology and rheumatology. So here are my disclosures. I've listed some pertinent manuscripts for you that I think will help to enlighten you on this topic and provide really intriguing approaches to thinking about the role and the contribution of IL-23/17 axis in these diseases. So what I'd like to talk about in the next 20 minutes or so is, first of all, the genetic basis of psoriatic arthritis, to review what insights we have about the disease from animal models, particularly mouse models, and then to talk about the contribution of interleukin-23 and interleukin-17 axis in disease pathogenesis and clinical benefits of blockade in psoriatic arthritis. So an important point is outlined on this slide, and that is that you have cells that are releasing molecules that are responding to IL-23. And so these are IL-23 activated Th17 cells on the top. And then you have cells that are producing interleukin-23 independent of IL-17. So let's glance up above at the IL-23 activated Th17. And of course, you're well aware this is through the transcription factor ROR gamma T. And as a result of the transcription of a number of important molecules shown within the nucleus of this cell, there's two key cytokines that are important in psoriasis, IL-22, and in psoriasis and psoriatic arthritis, IL-17A and F. And you can see as you move right from the receptors there that these cells, particularly IL-22, can activate keratinocytes, also can have actions, although not as potent, on B cells, macrophages, and that IL-17 and osteoclast precursors. And of course, IL-17 we know is a very pleiotropic cytokine, has very many effects on different cells and can activate and act on all of these cells as well. If you glance below to the IL-23 producing cells, you can see here that they bind obviously to the IL-23 receptor, which is made up of the P40 and P19 subunits. And IL-23 can activate a number of key molecules, including rank ligand, as well as activate other monocyte and macrophage populations to result in inflammation and matrix destruction. So it's important to keep in mind these dependent and independent pathways, because it may explain, we don't know yet, why it is that blockade of IL-23 alone may not be effective in axial spondyloarthritis, whereas it is effective in psoriasis and psoriatic arthritis. I'll speak about that more in a little bit. It's important to understand that the IL-17 is a family of isoforms, and there are 5 of them, IL-17A through F. I'm only showing the A and F here because these are the predominant molecules that drive inflammation in our disorders. And you can see that you can have various heterodimers, IL-17AA, AF, and IL-17FF, and that they can bind to IL-17 receptors that can have different configurations, as shown here, and that ultimately these can converge on P38, resulting in the activation of 2 key cytokines that you all know well, including NF-kappa B and AP1, or the June-Phos pathway. So these are the key elements that of IL-17 signaling. I'm not showing you the IL-17 receptor, which is very complex and interesting, but it's important to understand at least this element for now. So let's move into the genetic basis of psoriatic arthritis. So it's known that there are IL-23 receptor alleles that are associated with psoriatic arthritis and psoriasis. So here you're seeing on the top a Manhattan plot, and you're seeing genes that are associated with PSA more than with control. And of course, what leaps out at you is HLA-C. Intriguingly, HLA-C is the dominant risk factor for psoriasis, but not so much for psoriatic arthritis. Even though it's there, it may be more related to the coexistence of psoriasis than to the arthritis. At least that's what evidence is indicating now. Which you can see other important molecules related to IL-23 activations, such as TYK2 on the right. TRAF3 IP2 is also called A20, and it's an important inhibitor in the IL-17 receptor. And then, of course, you can see over on the left IL-23 receptor. If you glance down below, I'm showing you related SNPs in the IL-23 region and the TNF-AIP3 region, comparing them to psoriatic arthritis in red and psoriasis in blue. And it would appear, and this has been confirmed by a couple of studies now, that these IL-23 receptor mutations and TNF-AIP3 are associated with PSA, but not so much with psoriasis. So these are some of the genetic underpinnings that provide links between IL-23 and psoriatic arthritis. So on the right, I've shown you other manuscripts that also support this relationship that I think are very well performed studies, but I don't have time to go into. But certainly, if you're interested, they're worth reviewing. What about insights from murine models in regards to psoriatic arthritis and SPA? Well, of course, this is an iconic study that was published by Jonathan Sherlock in 2012 with a beautiful picture by Rick Lorre's in that particular journal. And this model, which was an IL-23 minicircle, which is an IL-23 minicircle plasmid injected into the tail of the mice, resulted in a very profoundly exciting phenotype characterized by enthesitis as well as inflammatory arthritis with elements of both bone resorption and bone formation. So you can see here, the model here is IL-23 is binding to a T cell population, which is resident to the enthesis. It's CD3 positive, but C4-8 negative, and expresses the ROR gamma T transcription factor. And in this model, this particular activated T cell produces IL-22 and 17, which mediate inflammation, bone loss, and osteoproliferation. I will tell you that the role of IL-22 in osteoproliferation is very controversial even still, 9 years later, although certainly we know that TNF and IL-17 can promote bone loss. However, we also know that TNF at low concentrations, less than 10 nanograms per mil, and IL-17 in certain contexts can also promote osteoproliferation. And this is very dependent, it appears, on the system that you use to test these bone formation events and also in the animal model that you use. But it's important to point out that mouse models of psoriatic arthritis can find different responses to a manipulation depending on the mouse strain. I'm showing you this here. So in the top left-hand corner in the column is the mouse strain, what they use to induce the arthritis. And you can see here IL-23 minicircle, IL-17 minicircle, or here IL-23 encapsulated in an adenovirus. You can see that the skin phenotypes vary in these three models. Some have psoriasiform lesions, one doesn't. One can see synovitis and bone inflammation and cartilage loss. Some of them get synovitis, but no cartilage loss. And then others with the adenovirus get degenerative intervertebral disease, synovitis, and cartilage loss. Interestingly, in two of the models, you see a very enhanced myelopoiesis. So if you look in the bone marrow, you see loss of the fat and expansion of the white cell population. We think this is very interesting and intriguing, and we're following up on it. But how these cytokines can influence the bone marrow population, which ultimately will be migrating either directly through these transcortical vessels in the bone or through the bloodstream to the joints and entheses, I think are a very intriguing area of investigation. Another element when you can use mouse models is with knockouts, and I'm just giving you this example. So there have been studies now, they're recently reviewed in the in a journal of experimental medicine, and that is that IL-23 intriguingly can regulate pain, and particularly the pain of inflammatory arthritis. So in this model, what the investigators do is they inject zymazin into the joint, and the zymazin causes inflammation and pain, and they measure the degree of pain by the time that the mouse spends off the injected knee. So they only injected one knee. So if you look over here in A to the right, in the y-axis is the weight on the ipsilateral hind limb. You can see that the wild type mouse here, that they're spending much less time on the hind limb than those that have the IL-23 P19 knockout, supporting the concept that the IL-23 is important in the perception of pain. Further examples here shown below is you're seeing that whether or not they have the knockout, they still have inflammation, but that their pain is greatly relieved in the absence of IL-23. So these kind of knockout models can really provide specific understandings of the role of individual pathways in disease, and I think are a very interesting way to use mouse models in terms of trying to move into translational approaches to human disease. So I want to talk now about the contribution of the IL-23, IL-17 disease axis to pathogenesis and the clinical benefits of blockade and PSA. So one of the really fascinating factors to me in psoriatic arthritis is that it is very heterogeneous and complex. So you have all of these various tissues that can be involved in the patient with psoriatic disease, including the skin, the bone marrow, the gut. We think there are important ties to the microbiome and the inflammatory axis linking to the joint. And then, of course, the target areas that are involved include the entheses and the joints. And the key pathways in the skin are likely to be IL-17 with a lesser contribution of TNF based on transcriptomic studies that came out of the Kruger lab at Rockefeller. We know that in enthesitis that there is a very strong component from what we can tell of IL-23 and IL-17, as well as TNF driving both inflammation and bone remodeling. And similarly, we see these pathways that are operative in the psoriatic joint. But I think it's important to underscore that within the various tissues, it's very likely that that IL-17, TNF, and IL-23 act on different resident cell populations and have different effects depending on which of the sites that you're looking at. And I think with the advance of single cell transcriptomics, we're going to have a much greater understanding of the cell populations, subpopulations that are operative in each of these tissue sites that will allow us to more appropriately individualize therapies for patients. I think that's a very exciting area that we're now entering into. So it's important to understand the pathway here and what we can use to block this very important pathway. So on the left, you see IL-23 producing cells, and you can block P40 with ustekinumab, P19, mainly P40 and briakinumab, and we know that this is effective in psoriasis, psoriatic arthritis, as well as in inflammatory bowel disease. And so this is a really important axis. We also know that you can block specifically P19 or IL-23, and there's 3 agents shown there, and these are very effective in psoriasis and PSA. Now, once the IL-23 converts a Th17 cell from one that is homeostatic or physiologic, because not all Th17 cells are pathologic, but IL-23 does drive that pathologic subset, that pathologic features. And we can block this cell population with IL-17A, and we know there are 2 agents that do that we treat our patients with now. You can also treat by blocking IL-17A and F. Those are 2 isoforms in that family I discussed. And then you can you can also block the IL-17 receptor with brodalumab. This is the bimekizumab, which blocks both IL-17A and F. So where are we in the treatment of psoriasis and psoriatic arthritis after having the first biologics approved in around 2001, 2002? Well, here I'm taking a number of agents shown down below, ranging from anti-TNF to anti-12/23 and 23s and 17s. And I'm showing you the ACR 20 responses and the ACR 70 on the top. This actually is a slide. It was a courtesy of Jose Scheer and Ian McInnes. And then down below, you're seeing the same agents and the effect on skin in psoriasis. And what you note is that the ACR 20 responses over time with the different agents have really remained pretty much the same, as have the ACR 70. In contrast, these agents have shown, particularly those that block IL-17A and 23, and to a lesser degree 12/23, increasing responses in the skin. Look at the PASI 75, and you can see the PASI 90. So the major obstacle for us in psoriatic arthritis is how can we achieve the same kinds of responses in the joint that we're seeing in the skin? I think the answer to that question was shown on the previous slide, and that is trying to better understand on an individual basis what are the key pathways and cell populations that are operative in these tissues in individual patients. And as I said, we're getting there. Now, let's just talk about some of the therapies that are out there. And I'm really excited we've had some comparative trials in psoriatic arthritis, which is something we've not seen before. So this is the Axial trial, which is secukinumab versus adalimumab, a 52-week musculoskeletal efficacy. These patients were naive to biologic agents. And what you can see here, they used a multiple imputation analysis for this 52-week trial. And you can see here that they did not see a significant benefit of secukinumab over adalimumab. And this was for efficacy. It wasn't non-inferiority. You can see here that the retention rate was higher for the patients that were on secukinumab. And if they had used a non-responder imputation analysis, which is commonly used in studies of shorter duration, they would have shown a superiority to secukinumab. It's also important to note that in the same trial, when they combined 2 outcome measures, the ACR 50 and the PASI 100 response, they saw a higher response for these 2 outcomes combined with secukinumab versus adalimumab. I should point out that Lilly trial performed around a year earlier, similar kind of structure in how they did this study, found similarly that combining the ACR 50 and PASI 100 showed a higher response for the ixekizumab versus adalimumab. I think somewhat surprisingly, when you look at the treatment emergent adverse events over in the table on the right, secukinumab in blue and adalimumab in red, these are very similar. It wasn't that the adalimumab had significantly higher problems with infections or with serious problems. So obviously, you can't make any strong conclusions in such a small study regarding adverse events, but one certainly can't give the benefit here to secukinumab in terms of these adverse events. So axial disease and psoriatic arthritis is a very hot area right now, mainly because we found that using agents that block IL-23 are not effective in ankylosing spondylitis. And so people have trying to understand the phenotype of psoriatic arthritis, axial disease. I think this is the best study that's out there. And this was from Deepak Jaden, who looked at patients in their clinic in Bath, England, that came in with psoriatic arthritis and ankylosing spondylitis, and they compared their axial disease in these over 200 patients in each group. And they found that about 43% of patients with PSA had radiographic evidence of axial disease, and that this was silent in about a quarter of them. 25% or so fulfilled the New York criteria. Their disease activity, metrology, and disability was comparable to ankylosing spondylitis, but there were a significant percentage of PSA patients who had spondylitis without sacroiliitis. And I think that's something that we've known, but this was a larger study that confirmed that finding. They also showed that radiographic axial disease was more severe in ankylosing spondylitis than it was in axial disease of psoriatic arthritis. So with that in mind, I think this next study, and this is just showing you, I'm sorry, up on the above, that these are agents that are typically being used now to treat axial spondyloarthritis. So when a patient has axial disease in the setting of psoriatic arthritis, these are the agents that we think about as we think about them in axial SPA. But I gave you that slide as a background to this study. So this is the Discover 1 and 2 trials, and you know them very well. This was looking at the efficacy and safety of guselkumab, an IL-23 antibody in psoriatic arthritis. But in a sub-study shown here, they selected patients who had inflammatory back pain and had evidence of abnormal radiographs historically. And these were an SI X-ray or an MRI in the Discover 1 population, which were all locally read, or a current abnormal SI X-ray locally read in Discover 2. So these were 312 patients that were about 28% of the total population. And you can see here that they looked at measures that are associated with axial disease, including the BASDI. They looked at spinal pain and modified BASDI, and over on the right, the BASDI 50. You can see the placebo in gray, the Q4 week and the Q8 week in the respective bars to the right. And what is really interesting and controversial right now, as I'll explain in a moment, is that clearly the patients that received guselkumab, remember they're being treated for peripheral arthritis, this is a subset, showed significant improvement in these outcome measures that are associated with axial disease. Now, one of the challenges here is there are studies that show that these are not specific to axial disease. Okay, so I'm just going to wrap up here quickly, but the other really interesting area is upadacitinib, which is a JAK1 inhibitor. And what was found in this study, again, it doesn't known to really interfere with the IL-23 pathway. And you can see with this oral drug, there was a very impressive ACR 20 and 50 and 70 response compared to placebo, comparable to adalimumab, which was the comparator over here in the study on the right bar in red. And you're seeing 2 doses, 15 and 30 of upadacitinib. And then you're seeing here the PASI responses, which again, for an oral drug, skin is quite impressive. So just also agents in the pipeline, the bimekizumab, which is the IL-17 A and F inhibitor, is in phase 3 right now. Filgotinib, unfortunately, was pulled from development, but there are also 3 other agents that are being studied that block interleukin-23. And then the BMS drug, deucravacitinib, is an agent that blocks TYK2, and it's an oral drug that's currently being investigated for psoriasis and psoriatic arthritis. And so with that, I also want to mention that there are other studies currently going on looking at dietary interventions in psoriatic arthritis by Alexis Ogidi and Lihi Eder. There are agents that alter the microbiome, nutraceuticals that are being examined, and also the idea of combination biologics are something we are entertaining because we see that we've not been able to advance our treatment responses, as I showed you earlier, with single biologic agents. With that, I want to thank you for your attention and be happy to take any questions.
Thank you, Prof. Richard, for this very comprehensive lecture. We have one question from the audience. A lot of biological DMARDs have more than 2 indications. Are IL-17s being investigated for other autoimmune conditions?
So I want to make sure I understand the question, so that we know that there are the biologics that we use are often used in more than one of our diseases: psoriatic arthritis, rheumatoid arthritis. What about other autoimmune conditions? Absolutely. I know we know that these agents are also used in inflammatory bowel disease. We know that they can have efficacy in uveitis. There are obviously some studies being, so far they've not been proven to be effective in atopic dermatitis, whereas other biologic agents that block IL-4 and 5 have. But I think there are broader implications in some of these biologics for treating a whole range of autoimmune diseases. And then the other element that I ended with was, what about combinations, and how will they be able to influence therapy for autoimmune diseases we didn't really think about with a combination regimen?
Yeah. Another question from Dr. Wagner is, it's interesting that ustekinumab was ineffective in spondylarthropathies, but guselkumab shows good response. What's the explanation for this differential effect?
So, excuse me. So I think there are a couple of explanations. We've been talking about this a lot, as you can well imagine. One is that we really need to be able to better classify our patients with axial disease and psoriatic arthritis. So we need to have radiographs that are read independently by experts, because we know that local reads are often not very accurate. So I think carrying out the study that was done with secukinumab, where they actually took that step, is going to be important. So I think that's one thing. The second element would be that maybe axial disease and psoriatic arthritis is different than axial disease in axSpA, where IL-23 is playing a different role. My own belief why the drug is not effective, meaning IL-23 inhibition in axial SpA, is because it looks like IL-23 is very important at the initial activation of the disease, but not in the persistence of it. So I think we're getting to the patients a little too late when the IL-23 element has already died down, and now it's driven by IL-17 and TNF. That's a hypothesis, remains to be proven.
Thank you so much. I think we'll have more questions, but for the sake of time, we'll have to move to the next lecture. Thank you. What's new in rheumatoid arthritis in 2020 is the title of the next lecture, which will be given by Prof. Arthur Cavanaugh. Prof. Arthur Cavanaugh is a professor of medicine at the University of California in San Diego School of Medicine. He's also the director of the Center of Innovative Therapy in the UCSD Division of Rheumatology, Allergy, and Immunology. Prof. Cavanaugh was involved with the formation of GRAPPA, and he's currently on the executive committee. He has been a board member of the Corona Consortium of Rheumatology Researchers of North America registry since its inception. And Prof. Cavanaugh has authored more than 550 peer-reviewed scientific publications and reviews and book chapters, as well as being on the editorial board of several journals. Prof. Cavanaugh, we're all very happy to listen to your lecture, please.
Well, thank you very much, Dr. Harifi, and I'm very pleased to be involved. I wish I was there. It would have been more fun and always more collegial to be there in person, but I guess we all have to do the best we can in this crazy year. So, but thank you very much for involving me in this symposium. So I'm trying to cover some new aspects in rheumatoid arthritis. Obviously, there's been an incredible amount, and there's been so many new developments. I'll just try to cover some that I think are useful, especially to us as practicing clinicians. So here are some disclosures, many of them related to the conduct of clinical trials. So this is not new per se, but I think there, of course, are always new developments in understanding the immunopathogenesis of disease, and that includes in 2020. This represents I think, a nice way to look at the immunopathogenesis of rheumatoid arthritis, insofar as what it shows are that the T cells, which migrate into the joint, really drive the orchestra that is the collection of other immune and inflammatory cells, and that gives us the onset, but also the sustaining of the immune-driven inflammation in rheumatoid arthritis. So all of these pieces work together and work together in such a way to give the expression of the signs and symptoms of disease that we see when we take care of patients. So what has there been that is new? There's a very interesting analysis published recently, the end of last year, in the New England Journal, where they did a very extensive analysis of a small number of patients. Initially, one patient who was sampled 364 times over 4 years. During that time period, the patient had a number of flares of disease as defined by a rapid 3. They assessed the expression of various transcripts by RNA-seq, and then they had some validation of this in other patients. So what they found is that in anticipation of the flare, they could track the pre-inflammatory mesenchymal cells, and that these increased before a flare. That seemed to have been driven by B cell activation. So highlighting the important role of B cells in the driving of rheumatoid inflammation. Now, we had known about this. We never knew exactly what to do with B cells. As I say, I think most of us learned that the T cells were really the orchestra leaders of the immune response driving rheumatoid arthritis. B cells, of course, seem to have an important role, if by nothing else, by the virtue of the autoantibodies, rheumatoid factor, and the anti-citrinated peptide antibodies. But this would suggest that the activated B cells, what else they will do is to recruit these prime cells, which then in the inflamed joint have a role that helps drive the inflammation and also causes some of the destruction. So I think these elegant analyses give us hope that we're able to understand more of the immunopathogenesis of disease, so that we may do even better with our targeted therapies. So that talked about the onset of disease, and looking at the onset a different way over time, you can see many diagrams like this, such as we see people on the far end of the curve who have established rheumatoid arthritis, and those are the ones that we're seeing in our office. But it would be better if we could see people earlier. We know from so many animal models of autoimmune disease that the earlier you intervene, the better you end up doing in terms of improving the clinical signs and symptoms. Now, this shows one of the challenges of thinking about treating rheumatoid arthritis very early, and that is that this process goes on literally for decades. There are points at which people who have some genetic predisposition encounter environmental or other stimuli, hormonal influences play a role, and then you have the earliest infiltration of immune cells, and then early undifferentiated disease, and then finally the full-blown expression of rheumatoid arthritis. So one of the challenges is identifying patients at an early stage, since this process has really probably been going on for quite a number of years by the time they see us in our clinics. Another challenge, and one that affects the idea of studying such patients, is that not everybody progresses all the way. In fact, there are data that if you look at a number of early arthritis clinics where they will get patients who don't quite meet the full definition of rheumatoid arthritis, but they have arthralgias, maybe they have inflammation on highly sensitive imaging, such as MRI. Only about half of those patients at most will go on to develop rheumatoid arthritis. In fact, if they're CCP negative, that number may be as low as 10 or 20% of patients ultimately go on to rheumatoid arthritis. So as we think about intervening, and there have been a number of studies that have looked at this, can we intervene early enough that we might be able to prevent the onset of rheumatoid arthritis? But we always have to remember that if we are treating patients, half of whom are never going to go on to develop the disease, we risk overtreating some patients, essentially preventing a disease that they were never meant to get anyway. This just looks at some of the studies. Prompt has been published and looked at methotrexate. In that analysis, and it's a elegant analysis, they found, as one might expect, that the closer someone was to fulfilling the classification criteria for rheumatoid arthritis, the more likely they were to ultimately go on to develop rheumatoid arthritis. This could be postponed by treatment with methotrexate, but once that was stopped, then it seemed that there was not a sustained benefit. The Prairie study used Rituximab. The abatacept has been used, hydroxychloroquine, even the statin, atorvastatin, although that study was recently stopped due to some methodologic issues and an inability to recruit patients effectively. But it's still a challenge in 2021 to say, how early can we treat patients? Which early patients should we treat to do the best we can? The idea is still a good one, and that is the idea we've had forever, that early on you have abundant inflammation, and that abundant inflammation over time causes damage, and that damage causes dysfunction. And of course, that's really what we're trying to prevent. So still a challenge in 2021. Are there any more data on treating early or very early disease? And this was a study that looked at very early rheumatoid arthritis. As you see, the definition of those here, and it was treated with etanercept plus methotrexate, so a TNF inhibitor, methotrexate, compared to methotrexate alone. And it was a treat-to-target study such that all of the patients were eligible to get the TNF inhibitor therapy. So what you see is that it seemed like it was effective, but it didn't seem that the earlier treatment before the patients were eligible for active treatment with TNF inhibitor, in the end, that didn't seem to matter. So the authors of this study actually took sort of a bit of a negative twist to it and say that there's a ceiling effect in achieving remission in a real life early RA cohort. So we're still a bit far away from treating early RA very efficiently, pre-RA very efficiently, such that we might prevent the ultimate development of RA. One of the problems that I think impacts our analysis is getting a lot more attention. And that's true in 2020 as well. And that is the non-inflammatory pain. So, and we certainly see this in the clinic. We see patients who have a lot of synovitis, and then we treat them. And by our measures, by our joint exam, maybe by imaging, the synovitis goes away, but they still have pain. And the question is, what is the cause of that pain? Is it structural damage? Maybe in some patients, certainly in those who've had arthritis for a number of years. Is it central sensitization or a complex pain syndrome like fibromyalgia, which we know some of our patients have, and they will never have that pain go away with our effective immune therapies if the active inflammation is not the proximate cause of all of their pain. So this is a sub-analysis of SWIFO that looked at that. And I think it has information that's useful to us as we think of clinical trial design, and also as we see people in the clinic, that maybe 15% of our patients will have non-inflammatory pain. Inflammation is completely controlled, yet they still have pain. Pain is, of course, important to our patients. Tremendous advances in 2020 in the medications available to us. So before we get to the biologics and the targeted synthetics, what about other agents? Non-steroidals. Is there anything new as far as non-steroidals, which many of our patients take, and we perhaps don't pay as much attention to them? They're certainly available even without a doctor's prescription in most countries around the world. But I think they still may have a role, and I think our patients show us that because they do use these drugs, and it does help with the signs and symptoms, including pain that they have. Corticosteroids. More than half a century later, we're still using them. Have we learned anything about using these drugs? And here we are talking about so many of these fancy new biologic agents and targeted synthetics, and yet corticosteroids also used by a large number of our patients, certainly early on or early in the treatment course. The traditional disease modifying drugs, still useful. And then, of course, tremendous progress made with the biologic agents, driven largely by the TNF inhibitors at first, but now with others, the IL-6 inhibitors, the T-cell costimulatory inhibitor, the B-cell inhibitor, and the targeted and synthetic drugs. So let's talk about some of these, beginning with the adjunctive therapies. I think this is an interesting study. As I said, non-steroidals, if we talk to our trainees, our students, our research fellows, they don't pay as much heed to them. And yet when we go to the clinic and we ask our patients, I'd say 70, 80+% of them are taking non-steroidals. I happen to use the number of non-steroidals patients take as kind of an outcome measure. And I tell patients that if you're taking 1,000 milligrams of naproxen every single day, then maybe we're not controlling your rheumatoid arthritis well enough. So maybe we should factor that in. Can we use these agents any better? We know that they can have tolerability issues. They can have safety signals. This is an interesting study in an animal model, so it doesn't necessarily have semblance to human rheumatoid arthritis, but I thought it was provocative. This looked in animals, and of course, rodents are the opposite of humans. They're active during the night and they sleep during the day. And it looked at chronotherapy of nonsteroidals, and it looked at an injury model. Bottom line is that there's a circadian rhythm to inflammation and wound healing, and those are, of course, maybe considered aspects of the same inflammatory process. In a bone fracture model, what they found that if they timed the non-steroidal dosing such that they treated them before the active period, it mostly had an impact on the pro-inflammatory features. Whereas if they treated them during the resting period, it had a negative impact on wound healing. So if you try to extrapolate these data to humans, it would say that maybe if we want to avoid some of the negative impacts of nonsteroidals, we should make sure that our patients are treated at the beginning of their active period, so early in the morning. Interesting that the idea of chronotherapy, that we should think of using our medicines optimally tied with the circadian rhythm, maybe tied also with the foods that we're eating. I think we'll see more about that later. Nonsteroidals used by a lot of our patients, as are steroids. And this was a study, Meisler published this. And I think this, I think it's a lovely study because it's kind of a glass half full, glass half empty. The bottom line, you could look at these and say, if you have patients on a very effective drug, the IL-6 receptor inhibitor, tocilizumab, with or without conventional synthetic DMARDs, who happen to be on prednisone at 5 milligrams a day, can you stop it? And the answer is maybe, that there are some people for whom you stop it who actually did better on that low dose of prednisone, whereas many of the patients you could stop it and they didn't. So we use prednisone as an adjunct. There's many analyses now about the risks even of these relatively low doses, certainly over time, but our patients do use them. And it's if we could learn further who benefits from these, and do we do something else then with their other therapies that would obviate the need for steroids? So it's still something that we're talking about. Methotrexate, our anchor drug, we use it all the time. And this was, I thought, an interesting analysis, Caleb Michaud, looking at how well patients take methotrexate. And of course, the most ineffective medicine is the one that your patient is really not taking. Small number of patients, but I thought it was fascinating that they knew they were being monitored electronically to see how often they were compliant with their methotrexate. And full compliance was very rare. 20% of patients took methotrexate perfectly. So, some of these mixed a week or two, but it's only a 24-week analysis. But I think it really highlights the importance that we have talking with our patients about adherence to the medication regimen so that we can really get their outcomes to be the best they can. Looking at the list of available agents, somewhat different way. Here you see all the biologic agents that we have, and tremendous amount. That would be an entirely separate lecture for each of these agents and classes. But we've had tremendous progress with these, I think we can all agree. And this shows one aspect of that relevant also to what you heard Professor Richland just talk about and what you'll hear in other disease states. And that is, this is really a broader list of immune modulating drugs, some of which are very useful for rheumatoid arthritis, but some of which are useful for other immune diseases. And Dr. Richland touched on that briefly, but I think we've learned so much about the actual diseases themselves from their response to specific targeted immunomodulatory therapies. And here you see in rheumatoid arthritis, tremendous success with TNF IL-6 inhibition, some with IL-1 inhibition, really not much with 1223 or 17 or 23 inhibition. The integrants, the anti-adhesion molecules don't work in rheumatoid arthritis. They do work for our colleagues in GI and ulcerative colitis and IBD. They work with our dermatology colleagues in skin psoriasis. So it's been fascinating to see in the era now of so many targeted therapies that I think they're really starting to define the type of patients that we have across rheumatologic diseases. Well, back to rheumatoid arthritis, treat to target is something I think all of us widely adopt. And I think we do this in our practices. What is the outcome of that? There was an interesting presentation at EULAR earlier this year, which looked at the BEST study, which I think was one of the really landmark studies in rheumatology. Early rheumatoid arthritis patients with symptoms less than 2 years. And of course, it tested various treatment regimens, but also tested treat to target. As you'd expect from treat to target, all the groups did well. Remember, about 15% of the people could have drug-free remission. This looks at survival after a long time, now after 17 years. And it says that we're still not, we've even with treat to target, even with putting many people in remission, we have still not eliminated the survival impact of rheumatoid arthritis compared to the general population. So do we need to treat even more? Is there some aspect of disease that we're not measuring? I think this is a fascinating, this was presented in an abstract form. And I think these analyses are important because we, of course, ultimately want our patients to do the best they can. So many therapies available to us, and how are we doing with them? Well, this is another slide that I think you might look at and say, maybe we're doing well. 20% or more of our patients across therapies are achieving an ACR 70, which is, I think, pretty close to remission. I think most of those people are in remission. You could look at that, though, and say, well, that means that 75 or 80% are not in remission. And if you looked at the patients who had been exposed to a TNF inhibitor before, that's even higher, maybe 85%. So although we're doing better than we did decades ago, there's still a long way to go. And frustratingly, we don't know which agent to pick. I think that's one of the biggest unmet needs in rheumatology is that we don't know which patient should get a TNF inhibitor, which patient should get a B-cell depleter, which patient should get an IL-6 inhibitor. This is a study done years ago, and there's really not been much since then showing that you might use biomarkers of some sort to predict this. I think where we're heading with this is big data. I think using artificial intelligence, because unlike cancer, where you may have one small alteration in one oncogene, and that really explains the development of the tumor, here it's too complicated. You have genetic influence, epigenetic influence, metabolomics. The things that we can measure are so many that I think we need to think of it more complicated. And that was done in this study. It looked at kind of different ways that one might use biomarkers as a reflection of what was going on histopathologically in the synovium. What about tapering medications? Hot topic. It's a very nice study just published, and I think it shows a couple of things. One is that if you taper, you do better than if you withdraw, but that many of the patients will ultimately flare. They do better if you taper than if you just stop them. The disappointing part, I think, really to me, is that there's no predictor. Even the amount of inflammation on MRI at the time they went to begin the taper did not predict who could successfully taper versus who would flare. So my patients try this a lot. I don't recommend it to them nearly as much as they do for themselves. I think partly financially, partly because they don't want to take medicines if they don't need to. But it's difficult because we can't tell the patients in 2020, because you're seropositive or this age or had this MRI score that you will do well. We just can't do that. We're looking more at response trajectories. And I think this is something we see in the clinic and we hadn't paid a lot of attention to in clinical studies. Namely, some patients do well really fast. And those are easy. Patients who come in the next visit and say, "Doc, that was fantastic. This is a nice medicine. I'm doing well." And we have patients, on the other hand, if you look at group 3 on the right, they don't do well. They try the medicine, maybe they improve a little. Then you have the group in the middle, and they do well, but it takes them longer. So I think this is something we see. Again, we don't have markers of which seropositive or seronegative or other characteristics that can define this response, but I think we see this across agents. It helps us in the clinic to say, maybe you should wait 12 weeks. And if you're absolutely no better at 12 weeks, then let's think of something else. Whereas if you're better at 12 weeks, you may get better. But it'd be nice to have predictors of this. Biosimilars, big in 2020, really across the world, more so than in the United States. It's coming here, and I think it will have a dramatic impact. One may be like my colleagues in the UK say, and maybe we can discuss this in the question period, if the acquisition costs of the TNF inhibitors are so low and so much lower than the other biologics, it's going to have an impact on how we treat patients, especially lacking biomarkers that would tell us what specific therapy to consider. The JAK inhibitors, tremendous development here. A lot of positive issues, and we've seen efficacy in rheumatoid arthritis, efficacy better than methotrexate, better than a TNF inhibitor, you might say. We've seen some issues, intolerability issues, the necessity to check laboratory tests, for example, to monitor for safe use. The issue of, most recently, of the VTEs, the venous thromboembolic events. So a lot of excitement with the JAKs. We have 3 available in the United States. In other countries, they also have 4. They have Citinib, and some countries have Filgotinib. We're still learning a ton about these, a topic all unto itself. Another topic that Dr. Richland alluded to, which I think we'll revisit, is combination therapy. So this was an interesting study now done in rheumatoid arthritis. Patients were given the TNF inhibitor, Certolizumab, and then if they didn't respond, they were given the IL-17 inhibitor, Bimekizumab. And if you look at the patients who didn't do as well and who got the Bimekizumab, you say that maybe there was a benefit. So, and this is in rheumatoid arthritis, where IL-17 inhibitors are really not that efficient. So with the JAK inhibitors available to us, with so many different agents, not to mention the traditional DMARDs, I think we will see in 2021 and on more studies of combination therapy across diseases, but certainly in rheumatoid arthritis. Potential safety issues. And I'm wrapping up here. These are, of course, very important as we deal with our patients, because these are things that we must talk about to them about before therapy. And the more we learn about these, the better we do. And then finally, the last slide, a whole separate topic on how COVID has impacted us in rheumatology. I think so many different aspects of this. The most recent for us now is, doctor, what do I do if I'm about to get the vaccine? What I do, I tell patients, extrapolating from the elegant data from South Korea on influenza vaccine, if they're on methotrexate, I tell them to hold the methotrexate for 2 weeks after their shots. Rituximab is very tricky to use in the era of when patients are going to get a COVID vaccine, because that can have impact on responses. But COVID is really, of course, one of the bigger topics in the world, in rheumatology, and in the care of patients with rheumatoid arthritis, and it continues to be into 2021. So with that, let me stop and say this is still our approach to treating rheumatoid arthritis. We weigh the potential benefits, we look at the risks, and we look at the patients and how their individual factors might impact. Let me stop here. Thank you for inviting me. Thank you for your attention. I think we may hopefully have time for a couple questions.
Thank you, Prof. Rana. Thank you for this very interesting and eclectic selection of advances and new papers in rheumatoid arthritis in 2020. We have a question here. Will gene therapy ever have a future in rheumatology?
Will gene therapy have a future? You know, I think it may. I think what we're seeing from our colleagues who are more interested in autoinflammatory syndromes, that you can have somatic mutations that can drive the autoinflammatory diseases for sure. I wonder if we will find that that's part of rheumatoid arthritis, and they're of course tricky to look at. But if that were the case, then we may have gene therapy. At present, the genetics are such a small contribution to the ultimate development, and also the development of disease may be many decades down the road. So I don't know if there is gene therapy. I would think it would be first for the autoinflammatory syndromes, and then maybe by extension into rheumatoid arthritis.
One last question, because we really need to wrap up here. Any upcoming head-to-head trials in JAK inhibitors?
Well, there have been some analyses from registries. I don't know of a proper head-to-head study, which of course would give the best information. There is the head-to-head study select choice of upadacitinib versus abatacept, which I think gave very good information. And if I had time, I would have covered that as well. So I think we will see them, nothing very soon though.
Thank you very much. Thank you. I would like to thank all the three speakers for the brilliant presentation.
Good evening once again. We are moving now to another area of rheumatic diseases, which is pregnancy and rheumatic diseases. We are welcoming Dr. Megan Close, who is Associate Professor of Medicine at Duke University and leading reproductive rheumatology, Director of Duke Autoimmunity in Pregnancy Registry. She has over 600 cases of the registry, in that registry. She was a core in the core leadership team to develop inaugural reproductive health guidelines of American College of Rheumatology. She has developed also website lupuspregnancy.org we can all refer to if we need any advice. And welcome Dr. Close for her, the stage is yours now.
Hi, thank you so much for having me today. I certainly would prefer to be in Dubai today, both because I've never been there and I've heard wonderful things, but also because I would love to hear about how you all manage pregnancy and rheumatic disease and the conversations that you have with your patients, and how they're similar or different from what I have here in the United States. So we're going to talk today about pregnancy and rheumatic disease with a quick tour through treatment, but really an emphasis on how you can work with your patients to improve outcomes. So my main disclosure is that some of this work has been funded by GlaxoSmithKline, and I'm going to show you our website, lupuspregnancy.org at the end, which was funded through an independent medical education grant from them. So these are three references. Basically, these are the American College of Rheumatology guidelines, as well as the EULAR guidelines about how best to manage rheumatic disease and pregnancy. And I think they're all terrific references for you if you have questions. So our objective today is to identify approaches that you can use to promote honest, accurate, and collaborative conversations about pregnancy planning and management in order to improve the outcomes of rheumatic diseases. So we went and talked to rheumatologists across the United States and asked them sort of what their main issue was, what was so hard about managing lupus specifically in pregnancy. And what came out of that was really an emphasis on ill-timed pregnancies, which I define as pregnancies that aren't really planned, maybe happen when lupus is active, maybe happen when a patient is not taking the right medications. And what we heard from doctors was actually a lot of anger. So here is a direct quote. I get angry when the patient comes in after multiple discussions on toxic medicine and oops, I'm pregnant, despite them getting depo or birth control or whatever. So we heard a lot of anger, a lot of feelings of betrayal from doctors that their patients maybe had been lying to them or had gone behind their back. And I think that this is something that we can actually address and not have as such a problem in the future. We know that unplanned pregnancies and these ill-timed pregnancies are problematic. And we sort of sense that as physicians, but the data actually really does support that. In the United States, about half of all pregnancies are unplanned, and that's actually fairly worldwide. In the United States, over half of them end in pregnancy termination, and many of them are born smaller and earlier than expected. And a lot of that is related to the women just not doing sort of the healthy pregnancy behaviors that we all know are important, like knowing they're pregnant and getting care early, not smoking, not drinking alcohol, that sort of thing. In women with lupus, we did a study of our patients, and we found that we really had much higher rates of severe pregnancy complications and 70% of severe complications for the offspring in these not planned pregnancies, with higher rates of pregnancy loss, early deliveries due to preeclampsia, and babies staying in the intensive care nursery for more than a week. We also saw fewer healthy behaviors. So fewer were taking prenatal vitamins, almost none, in fact, were taking prenatal vitamins in an unplanned pregnancy. Fewer were continuing their pregnancy-compatible medicines, and many conceived when their lupus was active. So this is really a problem that we actually need to address. And I think that we can address it. It's a challenge. We cannot prevent every unplanned pregnancy for sure, but we can actually make some impact, I think. And my goal is that we all transform these ill-timed pregnancies into planned pregnancies in order to improve outcomes. The benefits are most obvious in lupus, but I think it applies across the board. So I think it's important for doctors as well as our patients to realize that they can actually improve their pregnancy outcomes. However, the window to do that, in my opinion, is before pregnancy. All right, so we can take women who are at very high risk for pregnancy loss because they're taking a medicine that causes birth defects or their lupus is really active, and we can actually decrease her risk, make her a low risk pregnancy if she controls those things, gets off the birth, the teratogen, et cetera. Similarly with preterm birth, it's the same thing. If we control their disease activity, if we use the right medicines, if we control their blood pressure, we can actually make them into a lower risk pregnancy. All right. So the ACR guidelines are out. I'm very proud of this. This was definitely a labor of love. It took us a very long time. And it has some really nice tables in it that you can use. You can print out, stick on your bulletin board in your clinic. But they are pretty long. It's actually over 30 pages. And so I'm going to try to distill some of that down for you today. So one of our key things is, I think, that pre-pregnancy communication is really important. And my goal is that you all are able to have honest and accurate conversations with your patients that are collaborative. So honest meaning that your patient can actually tell you what she wants. Many of our patients, at least here in the United States, are very afraid of telling us that they want to get pregnant. They assume we're just going to say no, or make them feel guilty for wanting to get pregnant, or make them stop all these medicines that are finally saving their lives. And so they don't really want to be forthcoming about that. Plus, we've seen from our data that some doctors are actually just giving inaccurate information. And so giving accurate information to women that applies to them allows them to actually work with you to make good decisions. So how do you actually do that? That is hard, I'll be honest. But the key is to start with an open-ended question. So a lot of our rheumatologists start the question, you're taking your birth control, right? That is not an open-ended question, right? So asking what they're thinking. You know, we found that if we asked an open-ended question, would you like to become pregnant in the next 12 months? 16% of our patients actually said yes. And it was sort of dependent on whether they were married or taking a medication that caused birth defects, but not entirely. 10% of our unmarried patients here in the United States still wanted to get pregnant in the next year. 10% of our patients taking mycophenolate still wanted to get pregnant in the next year. Lupus activity didn't predict their desire for pregnancy at all. And a third of our women who were interested in pregnancy had very active lupus at the time. So you can't just assume that because her lupus is terrible that she doesn't want a baby. They're really not related, actually. So it's important to make this routine. Come up with sort of the most comfortable way for you to ask it. It might be that you ask it. Maybe it's that your nurse asks it on the way in the door. Maybe it's that you have it on a handout that the patients can do. If it's not a comfortable question for you, just find another way so that you can access this information from the woman and she can feel comfortable telling it. So now we're going to move on to management quickly. And we're going to talk about inflammatory arthritis, systemic rheumatic diseases, and then we're going to talk a little bit about breastfeeding. So first, inflammatory arthritis, and this is really my overarching kind of theme for the next, few minutes here. Controlling disease with pregnancy-compatible medications is really the key, all right? The days of sort of just stopping everything and hoping things go okay, and if not, giving prednisone is really not how we get to optimal pregnancy outcomes. That leads to women in pain, women not getting pregnant effectively, and poorer pregnancy outcomes. So really controlling disease with pregnancy-compatible medications is my overarching theme for all of rheumatic disease. So indeed, inflammatory arthritis can get better in some patients, but in my experience, not as much better as you think it might. My sort of adage is pregnancy is good, TNF inhibitors are better. If you look at pregnancy data from the Netherlands, for example, well over half of patients still had moderate to severe disease activity through pregnancy. We also know that having active disease, moderate to severely active inflammatory arthritis in pregnancy increases the risk for preterm birth and small babies and so on. And so, and prednisone actually probably just exacerbates that. And then rheumatoid arthritis does flare postpartum. That is definitely still true, but only if you let it. So I actually restart medications if people have stopped them, or I escalate medications if needed soon after delivery. And we really avoid almost all of our postpartum flares that way. So here's the sort of broad overview of all of our inflammatory arthritis medications and whether or not you can use them in pregnancy according to the American College of Rheumatology guidelines. So pregnancy compatible hydroxychloroquine, sulfasalazine, one of my favorite medicines for this, azathioprine is actually FDA approved for rheumatoid arthritis. We don't use it a lot for it, but it actually can be quite effective and is safe in pregnancy. TNF inhibitors, there's actually very nice data showing safety. Certolizumab does not really cross the placenta in any kind of significant amount, so it can be continued through through pregnancy and breastfeeding. The others do transfer across the placenta a fair amount, particularly close to delivery. So I usually stop them 1 or 2 months prior to delivery, but I continue them throughout trying to conceive and then pregnancy until the very end. And prednisone you can use, but to be honest, it's my least favorite medicine on this list, and it's been associated with preterm delivery, and so I use it very sparingly. Biologics beyond TNF inhibitors, there's really just not data to tell us what to do with these. They probably don't cross the placenta in the first half. I'm sure that they cross the placenta in the second half. There's really just not safety data yet on these. Leflunomide is we thought was a terrible teratogen and caused major birth effects. Actually, in humans, it doesn't particularly. We do recommend washing it out with cholestyramine, and I don't ever continue it in pregnancy. And then the newer small molecules that are coming out, I didn't even give the full list because it keeps on growing. We just have no data on them, and they are of the size that we expect them to cross the placenta. NSAIDs are pretty controversial. Ask your local obstetricians about that. Methotrexate is really pretty much the only known medication that causes birth defects in inflammatory arthritis world, which is nice to remember. There's only one. So my management pre-pregnancy, I switch people to pregnancy-compatible medicines. If they are on methotrexate, I don't just stop them and let them flare. I usually replace it with something else, sulfasalazine, azathioprine, a TNF inhibitor if they're not on it. In pregnancy, just continue their pregnancy-compatible medicines, and they need to take enough of it that they avoid prednisone. That's sort of my line. My patients know what that means. I let people take a little bit less TNF inhibitor if they're doing great, but they need to take it enough that they don't need prednisone. And then postpartum, I returned pretty quickly to whatever was working pre-pregnancy. Within a week or two of delivery, you have sort of 1 to 3 to 4 months in order to where the flare happens. So you really want to get them on the most effective meds before the flare happens. Because if you've had a baby, you know that it's a terrible time to not be able to use your hands. Okay, sorry. Now we're going to move on to systemic rheumatic diseases. I can tell you all the data is on lupus. However, I use the same principles for myositis, for scleroderma to some extent, for vasculitis as well. So the goal is that you have the woman as healthy as possible and you identify it and then decrease any kind of risks that you can. So first off, I always assess current and recent inflammation. However, her disease has been in the 6 months prior to pregnancy is probably how it's going to be during pregnancy, as long as the medicines are not changed. So if she's been really active, you need to treat her proactively. If she's been in remission, then continue whatever pregnancy compatible meds you can. And then you should be seeing these patients at least once a trimester. That's the recommendation in the American College of Rheumatology guidelines. And your job is to really assess how active her disease is. Obstetricians are great at delivering babies. They are terrible at assessing how active lupus is, and that's really your job. That's what you're good at. Controlling hypertension is actually very important in terms of pregnancy success. That's how you get a really good placenta. And so work with your high-risk obstetrician on getting that done for your patients, ideally pre-pregnancy, but certainly during the first trimester, it's really important. Whenever somebody wants to get pregnant or shows up pregnant, I check their antiphospholipid antibodies. If they're positive, but they haven't had clots or pregnancy complications in the past, they get aspirin. If they have had clots and or pregnancy complications in the past, they get low molecular weight heparin with their aspirin. And then I always check Rho and Law antibodies. So the reason why I check these antibodies is for neonatal lupus. So neonatal lupus occurs when the maternal Rho antibodies cross the placenta. That usually starts around 16, 18 weeks. Most fetuses, totally fine in 90% babies. Cutaneous neonatal lupus rash, which looks sort of like subacute cutaneous lupus, predominantly on the face, happens in less than 10%, and it goes away in a couple of months. However, 1 to 2% will develop congenital heart block, which is a permanent slow heartbeat. And it goes up to almost 20% if the woman has had a prior infant with neonatal lupus, either rash or heart problem. We know this happens because of damage to the AV node at a very specific point in pregnancy, which is about 18 to 24 weeks. 15% of babies who develop this will die either in utero or within the first several months of life. And those are generally the babies with very slow heartbeat. And many will need pacemakers. So we try to avoid this whenever possible. And this is terrific data that's come out of New York University and Jill Byen, in which she has actually shown that giving women hydroxychloroquine prevents congenital heart block in their babies. So 54 women, she gave all of them hydroxychloroquine, 400 milligrams every day, starting ideally pre-pregnancy or very early in pregnancy. These were women who had had a prior infant with congenital heart block. So we knew that 9 or 10 of these babies should have had heart block, but only 4 did. So it really decreased the risk by about half. So I personally now give 400 milligrams hydroxychloroquine, ideally starting before, but as early as possible in pregnancy, to every patient I see with Rho antibodies, regardless of her weight. I always give 400 milligrams, and regardless of her rheumatologic diagnosis. Even in my world, if she doesn't have a rheumatologic diagnosis, I still try to give her hydroxychloroquine. So we're back to our adage, control disease with pregnancy compatible medications as the key here. So I replace prednisone with pregnancy compatible medicines as much as possible, particularly as patients that are going up and down on their prednisone all the time and having flares every month or two. Those patients need more medicine. All right. So I use azathioprine as my first line for those patients. So here's the picture with all the medications. Those in purple are sort of the added ones that we particularly use in our systemic rheumatic diseases. So hydroxychloroquine, azathioprine, we're adding cyclosporin and tacrolimus here. Colchicine for pericarditis is fine. Our TNF inhibitors here, I still think prednisone should be used sparingly, though you need it if somebody's having a terrible flare of her lupus in pregnancy. In terms of biologics beyond TNF inhibitors, I want to just say a word about Rituximab. So people are using this more often now. I use it more often now. I have a patient, for example, with ANCA vasculitis who's getting Rituximab every 6 months to maintain her quiet disease. I continue on that regimen while she's trying to conceive. And then I try to sort of time her pregnancy dose towards the end of the first trimester before we think it would really cross the placenta a lot, around 16 weeks. I try to place it there if we need to. Some people who are doing great and just get it and then conceive right away after might not need it in pregnancy. I try not to give it in the second half of pregnancy, however, because it will result in some babies being born without any B cells for quite a while. And then it's worth talking about the teratogens here. So these are the diseases for which we use major teratogens. Methotrexate we all talk about and get excited about, but it actually causes about 8% birth defects. However, mycophenolate, cyclophosphamide, and thalidomide all cause about 25% birth defects in live babies. Unfortunately, many babies that are exposed are lost, so about 40% pregnancy loss. But of those live babies, 25%, 1 out of 4 will have a major birth defect. And with mycophenolate is often a facial abnormality or absence of functional ears. So these babies can be deaf. So it's really important for our systemic rheumatic disease patients in these medications that we adjust them pre-pregnancy. You also know with systemic rheumatic diseases that somebody on mycophenolate usually needs mycophenolate for a reason, right? So if you stop it, she will flare. So I usually try to switch people to azathioprine. I can tell you this is not perfect, all right? So I've had plenty of patients flare and not successfully make this transition. However, what I try to do is have the patient very stable and quiet on mycophenolate for at least 6 months, and then I transition. There is no data to tell you how to transition. I base how I transition on how much mycophenolate she's on. If she's not on very much at all, I might transfer faster. If she's on 3 grams, I transfer slowly. How sick she's been and sort of how long ago that was. So somebody who had really terrible lupus nephritis a year and a half ago and is on maximum dose mycophenolate and now wants to get pregnant, I will do a slow taper of mycophenolate while I'm ramping up azathioprine so that they cross. You have on both drugs at the same time. If she has been in remission for the last 5 years and is just taking 500 milligrams of mycophenolate, then I might just stop it one day and start her on azathioprine the next. So you have to use your judgment on that. And then I want patients to be stable on azathioprine without mycophenolate for a good 3 to 9 months, or you pick the number, really. It depends again on the risk that you perceive based on her history. If you need to add tacrolimus, you can. Maybe add rituximab if you need to think about how to keep her controlled. So other things, start a prenatal vitamin when you start talking about this. All right, so prenatal vitamins don't hurt anybody. A little extra folic acid and vitamin D is good for most of our patients. Start an aspirin at the end of the first trimester in women with systemic rheumatic diseases. It decreases the risk of preeclampsia. And then hydroxychloroquine is recommended in all women with lupus who are pregnant. So I want to show you this website. It is lupuspregnancy.org. I'm very proud of it. I'm going to take a moment to go and show it to you, I hope. But you can go there yourself. It has lots of information for patients and for providers. We have a lovely page that is about preparing for pregnancy and walks you through this conversation with patients, and even has a handout that you can print. These are free to use. Please use them. And it helps you walk through the information. It has all the medicines on it, so you don't need to remember everything I just told you. It has this on it for you to use for reference. And then you can also have the patient take it to her obstetrician, which I hope will help with communication. Get back to where I was. Okay. So finally, a few moments about breastfeeding, and that is that I will go quickly. Women do not need to choose between breastfeeding and their health. All right, we know that a lot of women think they do, but you can actually use almost all of our medications during breastfeeding very safely. So NSAIDs, so all of our medicines that are compatible with pregnancy are also compatible with breastfeeding. I will add to the list, NSAIDs are now considered quite safe in breastfeeding. And I also will add biologics beyond TNFs. So if you had a patient who really hasn't been doing great on a TNF and really wants to go back to her abatacept after delivery, fine. It is a big, huge molecule that is IgG. that really does not transfer into breast milk at all. There's not great data telling us, but there is really theoretically and scientifically not a way it can transfer across the placenta. The only medications that really in the guidelines we say don't use are ones for which there's really limited information. The drug is very small and there is some potential for risk. So it's really our small molecules, our major teratogens, and our newer small molecule medications. So with that, my final points are be proactive. Start talking about pregnancy planning because that's how we actually make pregnancy outcomes better. Start with an open-ended question. Don't assume you know about her reproductive goals. And please try our handouts. We would love to get your feedback about how they might work for you, both to help you give accurate information, but so the woman can also share that information with her family, her obstetrician, and everybody can work together towards having the safest pregnancy possible. And with that, I'm happy to take questions.
Thank you very much, Dr. Close. We have been bombarded with a few questions. So quick answers, please.
Yes.
Do you modify the vaccination regimen for people who were on anti-TNF during pregnancy? Vaccination for baby.
So I don't change anything about COVID vaccines as soon as they can. I am babies who are exposed to medicines that cross the placenta, like adalimumab, TNF inhibitors that cross the placenta. We generally don't give them live vaccines. So the rotavirus vaccine is what we give in the United States, but that would also include the BCG vaccine if that's what's given in your country to babies. It should not be given to these babies.
Right. Another one. A lady pregnant, let me say 2 months, and she was on methotrexate, never stopped. What do you do?
Yeah, good question. We have a page about this on the website that walks you through it. So obviously stop the methotrexate right away. It's helpful to have whoever answers your phone, your nurse, to like have a list of those 3 medicines, mycophenolate, methotrexate, cyclophosphamide, to tell the woman to stop those immediately if she gets pregnant. Increase folic acid to 5 milligrams every day. And then I have them follow up with the high-risk obstetrician as soon as possible, who is really good actually at managing these situations because they see a lot of patients who conceive on medications that cause birth defects. I do not personally advocate for terminating those pregnancies unless the woman is particularly interested in that.
Right, very good. Do you use rituximab on the 2nd or 3rd trimester in pregnancy for active lupus?
I don't.
You don't.
I don't use rituximab a lot for lupus, and I don't.
Have you come across a case of Cimzia causing abortion? Because it's in their literature. Might cause abortion, and one of our clinicians.
Yeah, so no, I have not. So there's really no real data that I know of that associates TNF inhibitors of any flavor, and certainly not Cimzia, with pregnancy loss.
Another question, like a case mimicking spondyloarthritis was on NSAID, very good. With the pregnancy, NSAID stops and she gets florid disease again. Steroids does help. So I guess I still think we can use anti-TNF here, Cimzia, but any thoughts on this one?
What was not working?
NSAID, she was controlled on NSAIDs, spondyloarthritis type of thing, yeah. And then pregnant, stop the NSAID, get a florid disease.
Yes, I would give her a TNF inhibitor.
Yeah, I guess. It's steroid in the interim. Breastfeeding disease modifying, what are suitable disease modifying therapy with the breastfeeding?
Say that again, I'm sorry.
What are the suitable disease modifying therapy, not biologic therapy, disease modifying therapy in breastfeeding, lactation?
Yes, there was a slide on that.
Yeah.
So almost everything is fine in breastfeeding. The only ones not fine in breastfeeding are mycophenolate, cyclophosphamide, leflunomide, and the new small molecules.
In fact, there are a few questions coming, but because we are short of time, I have to say thank you, Dr. Close. Sorry for the lights went off. I'm in a hotel and there suddenly they went off.
No worries.
And now we have to move on and appreciate your talk. Great.
Thank you so much.
Thank you very much. We are moving to another area, which is the vasculitis, and we always need to hear about what's new in vasculitis, and we welcome Professor Philip Seo. who is from John Hopkins Center, and he's the director of the Vasculitis Center in John Hopkins. But also he's involved heavily in the training committee with the ACR, and he is also associate professor in medicine. He is the director of rheumatology follow-up program and sitting with ACR committees, both in vasculitis guidelines as well as in a training examination task force. So he's heavily involved in all these aspects. I would like to welcome Professor Siu for the stage, bearing in mind we are already 2-3 minutes late. I hope he can catch up with time. Stage is yours.
I'm going to mention that even though I work in Baltimore, Maryland, I grew up in New York, so I can talk awfully fast. So you may regret having said that, but I will definitely keep an eye on the time. It's a great pleasure to be with you here this evening. As I think all the other speakers have mentioned, we're just all sorry that we can't do this in person, but hopefully next year the universe will start writing itself. So the object of my talk today is these are the formal objectives of my talk. But what I wanted to mention is that really what I'm going to do today is I'm going to take the topic of systemic vasculitis and I'm going to make it seem just a little bit harder. So let me explain what that means. So generally when I'm asked to give an overview of vasculitis, there's just so much territory to cover that I find that I end up having to leave out a lot of important details. So you lose a little bit of the nuance. So what I decided to do today is a little bit different. Instead of trying to cover everything that you need to know about vasculitis, I'm going to pick just a handful of articles that have really changed the standard of care over the last few years, and we're going to drill down. And we're going to talk about what those studies demonstrated, what they didn't show, and what questions still remain open. So these are some of the references that we'll be discussing today, and I have no relevant disclosures. So in the first part of my talk, I'm going to talk a little bit about giant cell arteritis. In the second part, I'll be talking about ANCA-associated vasculitis, meaning granulomatosis with polyangiitis and microscopic polyangiitis. And in the last part, I'll be talking about eosinophilic granulomatosis with polyangiitis, or EGPA. So let's start by talking about giant cell arteritis. And in order to do that, I'm going to be talking about the GIACTA study, which looked at the use of tocilizumab for the treatment of giant cell arteritis. Now, I know that many of you are familiar with GIACTA, and I don't want to belabor the details. Basically, just to remind you of the format of the study, remember that the study took patients with either a new diagnosis of giant cell arteritis or a history of relapsing disease and randomized them to one of 4 different treatment groups. Some patients received tocilizumab once a week, plus a 6-month prednisone taper. Some patients received tocilizumab once every other week and a 6-month prednisone taper. Some patients received just the prednisone taper by itself over 6 months, and some patients received a prednisone taper by itself, but over 12 months, which I think comes closest to mimicking what I would consider to be the standard of care. So these are the Kaplan-Meier curves that appeared in the article regarding the risk of relapse in the different treatment arms, but let's try to break this down a little bit. So let's start by talking just about the tocilizumab treatment group, the patients who received treatment with tocilizumab plus steroids. The top bar in green represents the patients who received tocilizumab once a week. The bottom bar in purple represents the patients who received tocilizumab every other week. And if you thought to yourself, those bars look awfully close, you would be exactly right. And in fact, for this primary endpoint, looking at the risk of relapse, the frequency of tocilizumab didn't make a difference. So the patients who received tocilizumab once a week did just as well as the patients who received tocilizumab every other week. Now, receiving a higher dose of tocilizumab definitely made a difference for patients with a history of relapsing disease. So if you had a history of relapsing giant cell arteritis, you did better if you received tocilizumab once a week. But for patients overall, it may not have made that much of a difference. Now let's talk about the placebo group. And I know we never talk about placebo groups, but I think there are 2 really interesting messages that we can learn just by looking at the placebo. So the patients in blue are the patients who received prednisone over a period of 12 months, and the patients in gold are the patients who received prednisone over 6 months. And the first thing that you can observe is that the treatment course makes a difference. So I know if you're like me, you've spent a lot of time arguing with internists or neurologists or ophthalmologists about why we're taking so long to taper patients off of prednisone. And the response is always that if you taper patients too quickly, they will relapse. And this is the most elegant proof I think we have of that concept. So if you taper patients off of prednisone over 6 months, they are much more likely to relapse than the patients who are tapered over 12 months. The second thing that I think you can learn from this is just how bad prednisone is as a treatment for giant cell arteritis. That even though it's been standard of care for decades, you can see that a lot of patients are going to relapse if you treat them with steroids alone. Now, I don't think that means that you can't use steroid monotherapy for the treatment of giant cell arteritis, because the majority of these patients will still do okay. When these patients relapse, they're typically having things like PMR. So they'll have musculoskeletal symptoms or a little bit of fatigue. They're not going to have like vascular events. So they're not having flares that involve like loss of vision or stroke. That said, you can see that prednisone by itself doesn't seem to prevent the majority of flares that are experienced by patients with giant cell arteritis. Let's talk about some more details. The first one is at the end of 3 months, at the end of 12 weeks of therapy, 85% of patients who receive treatment with tocilizumab are already in remission. And we'll talk a little bit more about that towards the end of this section. The adverse events associated with the use of tocilizumab in patients with giant cell arteritis are exactly what you would expect from using tocilizumab for the treatment of rheumatoid arthritis. And of course, the patients who receive treatment with tocilizumab have less in terms of prednisone exposure. Now, I told you before that weekly tocilizumab is better for patients specifically who have a history of relapsing disease. The other interesting thing is that patients who receive weekly tocilizumab just feel better. And we know that in terms of measures of quality of life, and we know that in terms of measures of fatigue, that the patients who receive tocilizumab at the higher dose seem to just do better overall. Now that comes at a cost. And the weekly tocilizumab is associated with basically a doubling in the risk of infection. Now, the interesting observation that was made in this trial is that that statistic only applies to weekly tocilizumab. So patients who receive tocilizumab every other week don't have an increased risk of infection compared to patients who are treated with prednisone alone. And I think that's a really interesting observation when you're dealing with a patient where the risk of infection may be high. So let's sum up. Remember that prednisone by itself is associated with an increased risk of relapse compared to patients who receive treatment with tocilizumab. But if you're going to use prednisone monotherapy for the treatment of giant cell arteritis, it's important to taper people over 1 year, because we know that tapering patients off of prednisone over 6 months is associated with an increased risk of relapse, even though the majority of those relapses are going to be pretty minor. What GIACTA demonstrated is that using tocilizumab either weekly or every other week is effective for the treatment of giant cell arteritis and decreases the rate of relapse compared to patients treated with prednisone. Weekly tocilizumab is better for patients with a history of relapsing disease. And patients who receive tocilizumab weekly also seem to feel better, but of course that occurs at the risk of an increased risk of infection. There's long-term follow-up already from the GIACTA study that demonstrates that treatment with tocilizumab for a year seems to result in a long-term decreased risk of relapse even after the tocilizumab is stopped. Finally, there's some unanswered questions. The first one is, does tocilizumab work just as well for patients with giant cell arteritis who predominantly have features of large vessel vasculitis, meaning patients who look like they have Takayasu's arteritis, except for the fact they're maybe 20 years too old? And the answer seems to be yes, from some initial data, but this is something that we'll know more about in time. The second question is, can we taper patients off of tocilizumab faster? So remember I mentioned before that treatment with tocilizumab results in 85% remission at month 3. So the question is, can we taper patients off of prednisone in 3 months rather than 6 months? And I think that's the direction that the field is moving. I can't recommend it for right now, but I think if you pay attention to this area in the next year or two, that's going to be the next frontier. So now we're moving off of giant cell arteritis, and we're going to talk about ANCA-associated vasculitis, meaning predominantly GPA and MPA. And in order to do that, we're going to talk about 2 different studies. The first one being Pexavas, which looked at the use of plasma exchange for the treatment of patients with ANCA-associated vasculitis. So Pexavas was a 2x2 factorial randomization because your lives are not complicated enough, but let me walk you through it. So they took patients with a diagnosis of ANCA-associated vasculitis, and they randomized them to receive either plasma exchange, 7 cycles over 14 days, or nothing. And then they took all those patients and they put them back in the bowl. And then they re-randomized them to receive either a normal course of prednisone or a reduced prednisone course. So what does a reduced prednisone course mean? Well, that means that patients started out with 1 milligram per kilogram of prednisone, just like you might do with any patient with severe ANCA-associated vasculitis. But then after that first week, they dropped. They dropped that dose to 0.5 milligrams per kilogram and then did a pretty standard taper after that. So the patients who received treatment with the reduced course of steroids received about 60% of the steroids we would normally use to treat severe ANCA-associated vasculitis. So let's first talk about the impact of plasma exchange for the treatment of ANCA-associated vasculitis. And this is one of those great graphs where you don't have to look at the legend because it doesn't matter what the colors mean. You can see that there's no difference between the 2 groups. So plasma exchange did not seem to have an impact on the primary endpoint, meaning the progression to death or the development of end-stage renal disease. I can also tell you that subgroup analysis seems to indicate that it also doesn't impact outcomes in patients who have pulmonary hemorrhage, although I know that that's one primary reason why many of us use plasma exchange clinically. The really interesting finding from Pexavas is the impact of the steroid taper, because you learned, like I learned at your mother's knee, that patients who have severe forms of ANCA-associated vasculitis need to be treated with high doses of prednisone. And yet that doesn't seem to be true. Because if you reduce that prednisone course by 40%, you can see that that doesn't seem to increase the risk of death, and it doesn't seem to increase the risk of progression to end-stage renal disease. Because again, these lines look exactly alike. Now, in American television, at the end of the program, at the last minute or so, they give you a preview. They show you just a little bit of what's coming up so that you'll tune in next week to see the next episode. And that's what I want to do today. So this is a subgroup analysis that was performed by the people who ran Pexavas. And what they found was that if you entered the trial already in renal failure, so you were already on dialysis, or you had a serum creatinine of greater than 5.6 milligrams per deciliter, it almost looked like you benefited from plasma exchange. And the reason why that's such an interesting observation is because we already have data looking at this particular group. And now we can do a meta-analysis combining the data from Pexavas with some of these older studies. And I can tell you that 2 groups have looked at this question already, and both of them seem to indicate that the use of plasma exchange for patients with renal failure does seem to help. So let's sum up. If you're one of those people who had a patient in the hospital who had ANCA-associated vasculitis, and you begged your hospital to get plasma exchange for that patient, and you just couldn't do it, I now give you permission to forgive yourself, because chances are it really wouldn't have made a difference. Now, the one exception to that rule is that the patients with end-stage renal disease may still benefit a bit from plasma exchange, and we're still waiting for those analyses to be published. Again, the really interesting message from Pexavas is we could probably get away with treating these patients with a lot less steroids than has been standard. The one piece of advice I'm going to give you is that this is very different than just accelerating the prednisone taper. If you just try to taper people faster but using standard doses, you're probably going to find that you run into trouble at the lower doses, where patients are going to find a fast taper hard to tolerate. Now we're going to switch gears and we're going to talk about Avacopan and the use of Avacopan for the treatment of ANCA-associated vasculitis. And I'm going to start with a confession. because apparently I've been lying to many of you for many years. Because generally when I'm talking about ANCA-associated vasculitis, I tell you it's quasi-immune, meaning that it doesn't involve either a complement or antibody. And it turns out that's actually not true. And the alternative pathway of complement is actually really important to the pathogenesis of ANCA-associated vasculitis. And the reason why we're talking about this is because of the drug Avacopan actually is a pretty specific oral inhibitor for that alternative pathway of complement. This led to a phase 2 study known as CLEAR that looked at patients with ANCA-associated glomerulonephritis and randomized them to receive either Avacopan or placebo, in addition to standard of care therapies. Now, the really interesting thing about this study is that they also randomized them to receive different courses of prednisone. So some people received high-dose prednisone, some patients received low-dose prednisone, and some patients received no prednisone at all. And you can see from this study that the patients who received Avacopan across the board did better than the patients who received standard of care therapy, even the patients who received no steroids at all. And that's what led to this study, the Advocate study, which looked at basically the same groups of patients. It was a double-blind randomized placebo-controlled trial that treated patients with standard therapies for ANCA-associated vasculitis, plus Avacopan or steroids. Now, that's an incredible thing to say, so I'm going to say that again. Patients received either Avacopan or steroids. So the patients who received Avacopan got no steroids at all in order to get into remission. The primary endpoint was the percentage of patients who were in a steroid-free remission at week 26, and these are the results. So 330 patients were randomized to receive Avacopan or placebo, and by week 26, the Avacopan group was non-inferior to the prednisone group. And by week 52, at the end of 1 year, the Avacopan group did even better than the patients who received treatment with prednisone. The other really interesting thing about this study is if you entered with kidney disease, you actually did better if you got Avacopan than if you got steroids. And of course, the group that got Avacopan had significantly less in terms of steroid toxicity. And Avacopan didn't seem to be associated with an increased risk of serious adverse events or serious infections, which is interesting, and we'll get back to that in a bit. So this is the Kaplan-Meier curve for the primary outcome, and you can see that Avacopan has significant impact on the outcomes of patients with ANCA-associated vasculitis, much more so than the impact of steroid treatment, which has been standard of care for so long. So let's sum up. Avacopan treatment results in remission in ANCA-associated vasculitis at a faster rate than prednisone in patients who are otherwise receiving standard of care therapies. And by the end of 1 year, Avacopan-treated patients do better than patients who are treated with prednisone. Avacopan is associated with a reduction in glucocorticoid-related toxicity, not surprisingly, when compared to patients who are treated with steroids, and patients who have renal disease at the time of trial entry also did better if they got treated with Avacopan. And the safety profile associated with Avacopan is very similar to the safety profile associated with steroids. And that's the interesting thing, because remember in clinical trials of ANCA-associated vasculitis, the serious adverse events are generally driven by all the steroids that we use. So it's really curious to me that in a trial where steroids are completely eliminated, patients didn't do a lot better in terms of serious adverse events or infections. And why that's true, I don't think is clear, and hopefully it'll be clearer when they do subgroup analysis. So in the last part of this talk, I wanted to move on to talk about EGPA. And in order to do that, we're going to talk about the MIRROR study that looked at the use of mepolizumab for the treatment of EGPA. So remember that interleukin-5 is basically fertilizer for eosinophils. It promotes eosinophil maturation, proliferation, and differentiation. And mepolizumab is a monoclonal antibody directed against interleukin-5. So the MIRROR study is a multi-center randomized placebo-controlled trial that looked at mepolizumab 300 milligrams subcutaneously every 4 weeks versus placebo, in addition to standard of care therapies for EGPA. In order to get into this study, you had to need 7.5 milligrams of prednisone minimum in order to keep your disease under control. And we'll talk about why that's important in a bit. The study was designed to last for 1 year and had 2 endpoints: the percent of patients achieving remission and the percent of patients achieving sustained remission. And let's just look at the Kaplan-Meier curve. So you can see here that patients started having equivalent disease, and then they started receiving mepolizumab, and you can see by month 2, mepolizumab is already making a difference. And then patients continue to have a sustained response to mepolizumab until the study drug was stopped. And after maybe 3 months, the effect of mepolizumab wears off. So you can see from this curve that mepolizumab has a significant impact on disease outcomes in patients with EGPA. And yet, every time I say that, I always have to admit, I really don't know what this curve means. And the reason why I say that is because you have to take a closer look at the patients that they enrolled in the MIRROR study. And when you and I think about ANCA-associated vasculitis, we're thinking about patients who have things like glomerulonephritis and pulmonary hemorrhage. But you can see that those patients, by and large, were absent from this clinical study. So even though the take-home message that you hear advertised is that mepolizumab is very effective for patients with EGPA, I don't think you can say that for all the disease manifestations. And if you had a patient who had a true vasculitis, who looked like they had like microscopic polyangiitis, for example, I would be really reluctant to use mepolizumab alone, because I just don't think we know if mepolizumab alone is effective for those disease manifestations. Where mepolizumab really shines is in terms of steroid sparing. So if you look at the study, you can see that the majority of patients started requiring maybe 12 milligrams of prednisone. And then when you get treated with mepolizumab, you can see that the steroid requirement goes down to maybe 5 milligrams a day. And that doesn't sound like much. I'm happy to admit that. But now you have to think of yourself as like a 20-year-old patient who may be facing being on 10 or 15 milligrams of prednisone every day for decades. And then you can see what a gift it is to give them a drug like mepolizumab, or you can bring that steroid requirement down to just a few milligrams a day. Now, just so I don't feel like I'm giving you a commercial for mepolizumab, let me talk about a few downsides. The first, remember that the dose approved in the United States for the treatment of EGPA is 300 milligrams, which is 3 separate injections once a month, which is, a pain in the neck. Now, it is true that one injection, 100 milligrams, may be effective for some patients. And for some patients who are reluctant to receive 3 injections monthly, it may be worthwhile to try the lower dose and see if they get a benefit. The other thing is when you start a patient with mepolizumab, please don't tell them that mepolizumab is getting them off of steroids, because a year later, they're going to be very upset with you. The vast majority of patients who you treat with mepolizumab will continue to require at least a few milligrams of prednisone in order to keep their disease under control. When you see a patient who has respiratory symptoms associated with EGPA, the mepolizumab is really more effective for the asthma component than it is for the sinusitis component, which can still be symptomatic in these patients. Now, the way I want you to think about mepolizumab is if you're looking at an EGPA patient and they basically have chronic eosinophilic pneumonia, meaning they have some sinus disease, they have some lung disease, but nothing else, mepolizumab is a great treatment for them. If you have a patient, on the other hand, who has like vasculitic manifestations like peripheral neuropathy or glomerulonephritis or pulmonary hemorrhage, I think it's fine to use mepolizumab, but I would use it in combination with a standard vasculitis medication like cyclophosphamide or rituximab. I want to mention the 3 different anti-IL-5 therapies that are on the market right now. The ones that we didn't talk about are reslizumab and benralizumab. Reslizumab is great because it's intravenous and it's weight-based. So someone my size, for example, would get a much higher dose than someone who's only 5 feet tall. Benralizumab is a more effective drug when it comes to the elimination of eosinophils. So benralizumab, in theory, should be a better drug. I will say that this is the subject of randomized clinical trials, and we should hopefully have an answer as to which is the superior drug for EGPA patients in the near future. And I think what I'm going to do is I'm just going to put my conclusion slide up, and I'm happy to take any questions.
Thank you very much for this very nice summary about the vasculitis in prospect. To start with, I have a question from Dr. Pranab Chaudhary from India. He just put a difficult clinical scenario in terms lupus with pulmonary hypertension and AAV clinical scenario. Would you choose cyclophosphamide or rituximab in these situations?
You know, that's a great question. I think it really depends on which disease manifestations are dominating. I think cyclophosphamide is an easy treatment to choose just because cyclophosphamide is definitely effective for both lupus and for ANCA-associated vasculitis. The one thing I'll mention is that patients with ANCA-associated vasculitis typically will need a higher dose of intravenous cyclophosphamide compared to lupus patients. So if you look at the the UVAS protocol calls for 15 milligrams per kilogram intravenously every 2 weeks for 3 doses, and then every 3 weeks for about 6 months or so. And that's significantly higher than the dose that's required by lupus patients.
Right. Yeah, thank you. I have another question here from Dr. Hala Al-Hadari. How we can differentiate between Takayasu disease or extracranial manifestation of GCA? Sometimes they present with peripheral.
That's a great question.
Yeah.
I will say that predominantly I cheat. So younger patients have a diagnosis of Takayasu's arteritis, and older patients have a diagnosis of giant cell arteritis. But this question probably refers to the patients in the middle ground, like the patients in their 50s, for example, where it's just really not clear what they have. I will say that there are some subtle differences in the vascular involvement between the two diagnoses. But when Peter Grayson looked at this years ago, he found that the mass majority of those patients in that sort of 50 to 60 year age range where it's hard to know exactly what they have, most of their vascular involvement tend to mimic more giant cell arteritis than it did Takayasu's arteritis. So I tend to assume those patients have GCA as well.
I think because of time, it was very enjoyable to speak to you, but because of time, we have to move on. Thank you very much, Professor. See you.
Thank you.
The last part of the original program, we still have symposia afterward, but the best part, how to finish the program, is to wrap up of what's going on in rheumatology. And the title is A Year in Review in 2020. I follow Professor John Jack Cush on his room now on Twitter. He is the director of clinical rheumatology and Baylor Research Institute, professor of medicine and rheumatology at the same center, clinical professor and of internal medicine as well, University of Texas Southwestern Medical School in Dallas. I always enjoy his updates because it summarizes a lot of reading time for me. Welcome, and the stage is yours, Dr. Kush.
Again, thank you so much for having me. It's a pleasure to be here in Dubai from my home. So I think I'd rather be in Dubai. But so today I'm going to do a year in review. These are my disclosures. I will talk about a number of biologics and in different indications. Most of these are on label. A few are off label. It's up to you to decide whether there's a conflict here or not. If you want a year in review, I write one every year on rheumnow.com. And this is the overview. This is a lot of the content I will cover in a little more detail, but I'll figure I'd get it out of the way right up front. As is the case almost every year, a lot of new drugs were approved. But interestingly, and this is, I'm going to give you the perspective of the United States, although 53 new drugs were approved, which is more than last year, none were in rheumatology for the first time in a number of years. Yet there was a lot of activity on drugs we know that are still nonetheless new and new indications. So polyarticular JIA has 2 new indications, 2 drugs that can be used there, and that would include Belumimab and tofacitinib. And I think that those are major advances because we need more therapies for our kids with aggressive polyarticular disease. I think a headline grabber for me as someone who is very interested in adult Still's disease was the first ever approval of a biologic for Still's disease. There are no drugs approved for adult Still's disease, and Ilaris or canakinumab was approved based on a relatively small study of about 60 patients, but nonetheless is approved. And the FDA, in doing this decision, basically said that kids with systemic JIA and adults with Still's disease really are the same disease. Now, there are a number of drugs that are approved for systemic JIA, including tocilizumab and canakinumab, as you know. But this is the first approved for adults. There were 2 new drugs approved, if we can count January this year, for specifically lupus nephritis, and that includes Belumimab and voclosporin, which I'll talk about. Psoriatic arthritis had a new approval with guselkumab, the IL-23 inhibitor. Very popular in treating skin disease, now going to be popular in treating the arthritis disease. And now we have 3 drugs that are approved for non-radiographic axial spondyloarthritis. This started with Cimzia last year, but this year in 2020, both Taltz and Cosentyx were approved for non-radiographic axial SPA. We're going to go over the new guidelines coming from EULAR in 2019 and ACR in 2020. Both were actually published in 2020. Filgotinib was sort of a very interesting story that I'll review. The FAST study, which I think is one of the best studies of the year, it actually looks at the safety of febuxostat versus allopurinol. The ACR reproductive guidelines, I think IRAEs had a lot of press this year, a lot more clarity, a lot more events are being seen with the wider use of checkpoint inhibitors. And then I reviewed in there some hope for scleroderma. Certainly, we have been hopeful that tocilizumab could be approved here, but there are some new studies that are really promising, albeit they are phase 2, with tofacitinib, a study out of Russia presented at EULAR, abatacept, romilcomab, and ziritaxestat, an autotaxin inhibitor. I'm going to discuss a few of these, but the other big thing, I mean, how can you talk about 2020 without talking about COVID? And COVID was a banner year, even for rheumatology. The 10 top things for rheumatology with regard to COVID was 1, the generation of the Global Rheumatology Alliance Registry, which was a rheumatologist-generated concept, idea, and in fact, registry, all generated from some Twitter discussion and promulgated by Janus Yazdani at UCSF and Philip Robinson in New Zealand, and really a tremendous effort. I'll show you a slide of that. Telemedicine, the world changed for all of us starting in March and April, and all of you went from being a new kind of doctor. I call you Zoomatologists, now that you can do telemedicine. We did learn that our patients in general have done really, really well, and that in fact our patients being controlled on aggressive therapies makes them at low risk for patients with COVID. I tell my patients, you're not immunosuppressed, you're not on immunosuppressives, you're largely taking anti-inflammatory therapy. And the good news is if you're taking a TNF inhibitor, JAK inhibitor, advanced biologics, the numbers are very, very low in your favor. Of all the drugs that our patients take, the one that seems most protective in a few studies is actually the TNF inhibitors. But again, even JAK inhibitors look very, very good. There are subsets of patients who have done somewhat worse. And these tend to be patients not with inflammatory arthritis, but with autoimmune disease that is active, and especially if they're taking steroids. So any of our patients taking 10 milligrams of steroids or above are at risk. Autoantibodies, we're experts in autoantibodies. It was interesting to me to see that a lot of the complications of COVID are being really, I think, put into effect by the presence of lupus anticoagulants and antiphospholipid antibodies. As you know, thromboembolic disease is one of the major complications of severe COVID infection. Hydroxychloroquine, a lot in the news. As we know, there was really no reason for it to be used in COVID. It did badly in COVID, and any of you think that actually hydroxychloroquine should be used in COVID, the data is so much against you, you should stop doing that. And we do know that a lot of our patients were unable to get hydroxychloroquine because of this tremendous run on this. I wrote about this yesterday in Room Now. There's a report from Annals of Internal Medicine that showed all the adverse events that occurred as a result of the overuse of hydroxychloroquine during the pandemic. A lot of our drugs are in play and can be used in the treatment of patients with COVID infection. That includes colchicine, the recently published Colt Corona study. A number of studies showing the benefit of IL-1 inhibition in patients who are hospitalized. Kind of mixed results with IL-6 inhibitors, sometimes not doing well, sometimes doing very well. It seems like that might be a story of when it's given more so than what yes or no, whether or not it works. Baricitinib, as you know, has a dual mechanism of action, one, controlling inflammation, but two, it actually inhibits endocytosis, thereby limiting the virus's access to the cell. And it, in combination with remdesivir, has been approved by the FDA, at least through an emergency use authorization, the EUA, for patients with severe hospitalized COVID-19. The new syndrome, the MSIC syndrome, the Kawasaki-like syndrome occurring in children. The interesting thing here is it's not children, it's generally adolescents, and meaning that they're over the age of 10, going up to like age 22. I mean, there are cases that are in the low 20s that have the same syndrome. And lastly, mortality rates. At least 400,000 or more of the 3.2 million deaths in 2020 United States were due to COVID. So here's the Rheumatology Alliance. They've been very productive in their research. There are well over 2,000 patients at this point. This is an analysis who is going to get hospitalized, basically showing that your patients on DMARDs were not at any higher risk. Your patients on that bolded line right here, biologic targeted synthetic DMARDs, had a lower risk, a 50% lower risk. And the ones that made up most of that benefit was actually the TNF inhibitors. And the ones who did the worst were those who were on 10 milligrams of prednisone or above, the bottom line in this slide. So I made a bit about non-radiographic axial SpA. The question is that a real thing, or is that something that's made up by the drug companies as another indication? As you know, what we're talking about here are patients who have inflammatory back pain, do not yet have radiographic evidence of sacroiliitis, but they have a form FRUST, if you will, or an earlier version of axial SpA, and it's proven by either having a high CRP or MR evidence of spondyloarthritis. And you know, I wasn't too sure about this. Actually, I was enrolled. I tried to be in a clinical trial with this. Really couldn't find any patients. Went to an FDA hearing about this, and as soon as I got home, I saw like 2 patients in one day and a third patient the next week. So these patients do exist, I believe. I think it helps to have this FDA approved, because now you no longer have to lie about the diagnosis. This is the data from the PREVENT study with secukinumab, or was given to non-radiographic axial SpA who had to have either high CRP or a positive MR. Almost 500 patients in this trial, and you can see the results, the top 2 lines in the graph on the right, showing a fairly stringent definition of response in spondylitis, an ASAS-40 response, because there's an ASAS-20, which is easier to achieve. ASAS-40 would be harder to achieve. A 42% response versus a 29% placebo. This was significant. No difference in all the other characteristics you'd see in someone taking secukinumab, for instance, no new side effects, etc. So this was the basis upon which that was approved. And then the COAST-X study with ixekizumab, also showing basically the same results, another 1-year study showing, as you can see at week 16, about a 40% ASAS-40 response. That's shown on the bottom right, the 2 green bars, compared to a 19% placebo response. In their studies, they actually showed that the SPARC scores, an MRI scoring methodology for SI joints, was actually better in those treated with ixekizumab at both week 16 and 52 compared to the placebo population. It was a placebo only got treated for 16 weeks. And the other big thing is, again, JAK inhibitors have enjoyed a lot of success this year. As you probably know, the JAK inhibitor upadacitinib, previously only approved for rheumatoid arthritis use, has recently been approved by the EMA for use in psoriatic arthritis and ankylosing spondylitis, based on data such as this, the SELECT AXIS study, looking at almost 200 patients with AS who were biologic naive, who received either UPA 15 or placebo. And you can see here at the primary endpoint, week 14, they were significantly better, 52% versus 25%. And then also their SPARC scores at week 14 were significantly better. They also had great data presented by Ian McGuinness at EULAR, looking at UPA in psoriatic arthritis patients. Very large study, 1,700 patients. Here they use the 15 and 30 milligram dose. In the United States, we only have availability of the 15 milligram dose. And that was head-to-head against placebo or adalimumab. And you can see at week 12, the primary endpoint is a 24-week study. Very good responses here. ACR 20 responses of 71 to 79% compared, and that was with the 2 doses of UPA versus 65% for adalimumab, and both of those were better than placebo. You can see that Going all the way out to week 24 on the right, you can see improvement in things like enthesitis and dactylitis, so it's improvement in skin scores. So again, there's a lot of interesting data coming down the line last year or two on the use of JAK inhibitors in general. Again, these are soon to be approved for atopic dermatitis. There's results showing that they work really well in a number of different skin diseases, including refractory dermatomyositis, including patients who have the Sappho syndrome I reported on recently, and as you know, alopecia universalis or severe alopecia areata. So speaking of new approvals, I think a major advance for us who treat lupus is new approvals for lupus nephritis. So just a few weeks ago, January 22nd, the FDA approved voclosporin. It's now called Lukinous. This is a drug that's been around for a few years. I think it was very smart of the company that generated this, Aurinia, to develop a drug not for lupus in general, but to go specifically after lupus nephritis. Number one, it is really the more difficult aspect of lupus to treat. And number two, it's actually an easier outcome to measure. Lupus outcomes, whether it's by SRI-4, Selena-SLEDAI, SLIC, a number of different criteria are fraught with very high placebo responses, and the therapeutic effects are very, very low in those trials, leaving one to wonder just really how good is a drug like Belumimab when it got its approval for a statistically significant benefit, but was it clinically significant? Hard to tell. It's easier to tell looking at a renal outcome where you're looking at things like UPCR measures. So this drug was approved based on two large phase 3 studies. A phase 3 and a phase 2 study. On the right, I'm showing the results of the Aurora phase 3 trial, 52-week outcomes where patients who are on background therapy either stay on background therapy with placebo, background therapy being mycophenolate, and these patients are also on steroids. And then the other group got mycophenolate plus voclosporin, and you can see significant benefits with regard to the primary endpoint, which again, they vary a little bit between these studies, but basically they look at renal function. Patients on voclosporin were twice as likely to have achieved their renal endpoints and have a decline in the urine protein to creatinine ratio. So again, and again, there was no other difference regarding whether you had class 3, 4, or 5 disease in this particular study, and the safety profile looked good. The drug is going to come out in a 7.9 milligram tablet. The usual dose is 3 tablets a day on background therapy, and you adjust that dose based on renal function and hypertension. After all, this is a calcineurin inhibitor, much like cyclosporin and tacrolimus, that you need to worry about high blood pressure and renal function. Belumimab did the same, and kudos to them for showing a great outcome in their nearly 500 patient trial in patients with class 3, 4, or 5 disease who received IV Belumimab, and the primary outcome was this primary efficacy renal response, PERR, at week 102, and you can see that overall, again, the bottom left showing you that the patients who are taking Belumimab in orange were more apt to achieve that outcome. And then on the right, the time to a renal-related event, renal failure or actually death, was actually much better and fairly, and I think blunted to quite a degree in patients on Belumimab, shown in orange. So kudos to those two drugs. That's going to help us in managing patients with lupus. RA management continues to always be the big challenge. We're always looking for an edge here. The rheumatologists like guidelines, or do they hate guidelines? I don't think we like guidelines when they serve our interests, when they reaffirm our practices. I always have a problem with guidelines because they're usually not truly evidence-based. Most of these are expert opinion. EULAR published its 2019 update to the recommendations on RA management. They published it in 2020. And the tenets are shown here. I'll quickly go over them. Start a DMARD as soon as possible. Treat the target is the way to go. Monitor disease activity. Methotrexate is your first drug. It's the anchor drug. And then after that, you could consider leflunomide or sulfasalazine. Remember that, because that's actually at odds with what the ACR says. They really recommend only short-term use of glucocorticoids when initiating or changing DMARDs, but you should taper and be off. If you are starting your first DMARD, CS, conventional synthetic DMARD, in the absence of poor prognostic factors, you should use another, what you would call it, another DMARD, oral DMARD. So if you fail methotrexate and you do not have poor prognostic factors, you should go to sulfasalazine or leflunomide, et cetera. Poor prognostic factors, as you know, are high acute phase reactants, high CCP and RF, radiographic erosions, many joints involved, et cetera. Okay? And these are important because EULAR still recommends the factoring poor prognostic factors into the decision making, whereas the ACR does not, because there's research that says it really doesn't matter in the end. But look at what happens if you, in the next bullet I have blocked out in red here, if you fail a DMARD, but you have poor prognostic factors, they recommend you switch to a biologic DMARD or targeted synthetic. So if you're going to use a biologic or a targeted synthetic like a JAK inhibitor, it should be combined with an oral DMARD, but they do note that IL-6 inhibitor studies do look good when used as monotherapy. If you're going to fail a biologic or a targeted synthetic, what should you do? They suggest that you could use another biologic or another targeted synthetic. If you fail one TNF inhibitor, they make the recommendation that you either switch your mechanism of action or use a second TNF inhibitor. That is a change from prior guidelines, basically saying that it's okay to switch within class, and then it's okay to then swap to other MOAs, but they do not condone going to a third and fourth and a fifth TNF inhibitor. If you're in persistent remission, should you taper? This drives me crazy. I'm not looking to taper, but patients want to taper. Some of you want to taper. What happened there? So sorry. Now, so sorry. I'll go back to where I was. Here we go. Sorry about that. So if you are in persistent remission, they recommend, and this is the difference with the ACR, that you taper the biologic or the JAK inhibitor first, rather than the oral DMARD. So the question is, why would you do that? I mean, and clearly, I think this is a financially driven decision because these are the much more expensive therapies. But they do note in their paper that you're more apt to recapture disease control if the patient flare is going off of a JAK or off of biologic, then and they say like 90% capture, and they said if you go off of or you taper the methotrexate, you may not recapture, maybe only 50% capture. And then later on, they do say that you can also taper the conventional DMARD. Now, ACR came out with guidelines, but actually informing those guidelines is a paper that was presented by Jeff Curtis at ACR. This is the SEAM-RA trial. This was a withdrawal trial, basically. A 24-week, 370 patients, and they had to be in SDI remission, meaning SDI score of less than 3.3, taking etanercept and methotrexate for 6 months. Those patients who were in remission, 253 of them, were then randomized to either stay on the combination of methotrexate and etanercept, or switch to monotherapy etanercept or monotherapy methotrexate. At the end of 48 weeks, you can see that being on combination therapy on the right was the far superior move, validating my view that we spend most of our life trying to treat rheumatoid arthritis. It's horribly difficult. We have to use combination therapy. Why are we talking about trying to get our patients off therapy, taper drugs, unless we're driven by finance or we're driven by the patients who want to be off drugs? And they want to be off drugs, but they got to learn whether that's prudent or not. Anyway, it's good to have this data. Next, you can see the one that did worse was methotrexate. Only 29% were still in remission at week 48. And interestingly, etanercept was also better than methotrexate by itself, but etanercept monotherapy was basically equivalent to etanercept methotrexate combination therapy. An interesting idea. You can see on the right the Kaplan-Meier plots showing that the dotted blue line was the combination group doing the best with the least amount of fall off, whereas the fine dotted white line is the patients on methotrexate alone. The other big caveat here is when patients flared and got worse on whatever arm, all of them did the same, meaning that 75% were able to recapture a remission with an SDI less than 3.3, and over 90% were able to recapture at least low disease activity state, whether you were on methotrexate, etanercept, or the combination. And there was always a step up in therapy to get there. So this is at odds with what EULAR has said, and this is incorporated basically in the ACR guidelines. So here are the guidelines. If you're in low disease activity state and you're starting out, they suggest that you use hydroxychloroquine over sulfasalazine and methotrexate. I got a problem with that because my belief is if I'm treating rheumatoid arthritis, I don't care who you are, what your problem is, how much activity, I'm using my best drug first. That's methotrexate. I'm not a big user of hydroxychloroquine. Yes, I know there's someone in whom it is appropriate, but it is not as efficient, not as effective. It's got its own toxicity. Yeah, you don't need to monitor very much, but I don't get this. Let me just start by saying actually that these treatment guidelines were based on 81 PICO questions. There were, I think there was about 40 panelists. I give them a lot of credit for coming up with these guidelines. There was a tremendous amount of work, but recognize of the recommendations that they made, 37 out of the 44 were conditional, meaning that it's expert opinion. That's it. There's not a lot of data, and this is one of the hazards of our guidelines, but nonetheless, people want guidelines, insurance companies wants guidelines, regulatory agencies want guidelines. If you have someone with moderate disease activity and they're DMARD naive, they do recommend methotrexate over all other drugs. If necessary, you can use methotrexate. They want methotrexate monotherapy over adding in hydroxychloroquine, sulfasalazine, or triple DMARD over. The idea is use methotrexate, use it a lot. If you can get away with monotherapy, great, but it's okay to use these other ones, but not until you've gone through methotrexate monotherapy, even with moderate to high disease activity. With regard to glucocorticoids, they basically say you shouldn't be on them. You should only be on them short term, and that you should, change therapies, change DMARDs, add on biologics rather than continue low dose prednisone, because it's clear from recent data, Jeff Curtis and others in Annals of Internal Medicine showing that even low doses, 5 milligrams and less, carries with it a serious infectious risk, hospitalizable infection. There's another report this year that came out showing that, again, 5 milligrams or less carries a significant cardiovascular risk. This is what really informs the idea that you should not be on steroids long term. They have some things about methotrexate I got to stop and talk about. Start oral over parenteral methotrexate makes sense. The next two lines are idiotic and wrong. If you're not tolerating oral methotrexate, they recommend you split oral or go to sub-Q parenteral or increase folic acid. Number one, there's no data that shows increased folic acid works in treating intolerance of methotrexate. Folate decreases discontinuations, this decreases LFTs, but it does not treat oral ulcers, nausea, diarrhea. If you're not tolerating oral and you go to split oral, you're actually giving more drug. You're not making the drug more palatable, you're giving more drug. As you know, at 15 milligrams above, you have variable absorption. You split that into split dosing, you get 100% absorption or 90% absorption. That doesn't make any sense. Same thing with going sub-Q, you're giving more drug. It makes no sense if you're not tolerating it to give more drug. If you're not on target with oral, they want you to switch to sub-Q or parenteral. I like that over adding on another therapy. Again, as I think taught in the past, if patients are having problems with intolerance, there are ways to treat that. You can give more folic acid, that doesn't work. If they're having queasiness, oral ulcers, and nausea, vitamin A, 8,000 units every day. Ask me about it sometime. I've written about it on my website. If they're having CNS toxicity, the blahs, and feeling flu-like for 24 to 36 hours after their methotrexate, that is a direct toxicity of methotrexate. You can block that by using dextromethorphan. And what I recommend is giving Mucinex DM, guaifenesin, with dextromethorphan in it, usually like 30 milligrams or so, with the methotrexate dose, and 12 hours later after the methotrexate dose, that works really well. Again, they strongly recommend treat to target. They strongly recommend, again, limiting the amount of glucocorticoids. If you're on max methotrexate, actually, I got to go on. So I can send you these slides. But let me end with the bottom lines, because this is really important for rheumatologists. They recommend that it's okay to continue methotrexate if you have lung disease and stable parenchymal lung disease. If you are hepatitis B surface antigen positive, you can't take our drugs most of the part, but you can if you're going to give antiviral therapy. They also recommend if someone is B surface antigen negative, but they are B core antibody positive, meaning they've resolved, or a cult infection, and you're starting rituximab, you need to be on chronic antiviral therapy. Patients with non-alcoholic fatty liver disease can take methotrexate if they have stable LFTs. Okay. So JAK inhibitors, we're approaching the end here. JAKs have been repeatedly shown to be better than methotrexate. They have been shown to be better than adalimumab and maybe even better than abatacept. Here's a meta-analysis from Kirschbaumer showing you again head-to-head the JAK inhibitors. This is outperforming on the right. JAK inhibitors, adalimumab being favored on the left. They do very well, ACR 20, ACR 50, ACR 70 responses. I think this is one of the important studies of the year. This is the Select Choice Head study. These are patients who are biologic DMARD, incomplete or non-responders, who are then randomized to receive either upadacitinib or abatacept. And in this study, 600 patients, were treated for, I think it was 24 weeks. 24 weeks was the primary endpoint. And they use a DAS28 CRP, and you can see on the left that the green is, which is upadacitinib, 15 milligrams, outperforms abatacept. The CDAI, which doesn't include the CRP assessment, still has the UPA doing better than ABA, 21 versus 14. A letter to the editor by David Felsen and I think Joseph Smolin pointed out that you would have predicted this result, since the JAK inhibitor is likely to indirectly inhibit IL-6 and lower CRP. So CRP containing outcome measures are going to look better than non-CRP outcome measures. And that was true. Actually, there's a mixture. A lot of other measures that don't require the CRP showed the drugs to be equal. But overall, it looks like there's an efficacy edge for abatacept. But wait, there's actually maybe a safety edge for, efficacy edge for upadacitinib. There is probably a safety edge for abatacept when you look at the outcomes. Like, remember, there's 300 patients in each of these groups. But let's look at something like opportunistic infections. There was just one with ABA. There was 4 with UPA. Zoster and VTEs were not different between the group, and that was a surprise. You would have thought that the JAK inhibitor would have done worse. But anemia was much more likely, 6% versus 2% with UPA versus ABA. Lymphopenia, same thing, 15% versus 8%. And grade 3-4 CPK elevation only seen here. And then LFT elevations or liver dysfunction, which is on here somewhere, hepatic disorders, 23 cases versus 5 cases. This is a bit surprising. So it depends when you're switching on someone who has not responded well to a biologic, whether you'll use the JAK inhibitor or the co-stimulation inhibitor, based on whether you're looking for efficacy or whether you're looking for safety. So the big, surprise this year was filgotinib. This drug was poised to be approved and has been approved in a number of countries. It was poised to be approved by the FDA. They had really good safety data. They had really good efficacy data. Very low zoster events, very low VTE events. But wait, things happen. So the drug has a name. It's called Jyseleca. It's a selective JAK1. In June, the EMA recommended both doses of this drug to be approved for use in RA. In August, the FDA issued a complete response letter basically saying, wait, we need to see the results of your safety data. And they wanted to see the results of the MANTA-RAY studies, which were looking at sperm function. And why were they doing that? They had some preclinical animal data that said that there might be testicular toxicity at doses that were high doses, like the 200 milligrams and above. So these studies were mandated. One study was completed, but not yet analyzed. The other one was in process. This was all on hold. But while it's on hold, a month later, the EU approves filgotinib and Japan approves filgotinib for use in RA. And then just recently, I think last week, the UK, NICE in the UK recommended filgotinib, both doses again for approval. And while we're waiting for this complete response letter, that usually means that there's going to be negotiations between the companies, which is Gilead and Galapagos, and the FDA. They announced in December that they withdrew their NDA. So we're not going to have this in the United States, but you're going to have this in Dubai and England and in Germany, et cetera. And whether that will change over time is not known. So filgotinib is going to be marketed internationally by Galapagos, and there are programs underway in other diseases, including inflammatory bowel disease, Sjogren's, IBD, even lupus. So VTE is the big issue with JAKs, is it not? But there was two important studies this year that looked at VTEs and RA activity. We know that the activity, inflammation, drives the risk. And that comes from the Swedish Rheumatology Quality Register 46,000 RA patients looked at by high, moderate, and low disease activity, you can see that the risk of VTE goes down significantly. Okay, this is important when you consider now the VTE risk associated with the JAK inhibitors. So the package insert changed for all of these, now saying that there's a box warning saying that you probably shouldn't use a JAK inhibitor, whether it's TOFA, BARI, or UPA, in patients who either have a prior thrombotic episodes or patients who may be at risk for thrombotic episodes. I must say that some of the warnings, even though the EMA warning is actually more stringent than what's seen in the United States, but nonetheless, these warnings are out there. So how do you handle this? First off, I would say that you should never use the higher dose of TOFA, BARI, or UPA. In the United States, TOFA is approved at 10 or 11 milligrams. BARI once a day. BARI is approved at 2 milligrams once a day, and UPA is at 15 milligrams once a day. All of those drugs had double those doses, and in some parts of the world, maybe in your part of the world, you can use the higher dose. But in all of these drugs, it is clear that there is a higher VTE risk with, and actually much more clearer risk of VTE with the higher dose. The risk of VTE in RA is about 3 to 5 VTE events per 1,000 patient years. Excuse me, that's a mistake on my part. That's 3 to 5 per 1,000 patient years. So the risk from the drugs is 6 to 8 per 1,000 patient years. So if you add a JAK on to an RA patient, you're really augmenting the risk by 1 or 2, at the most 3 VTEs per 1,000 patient years. So the idea is if someone has a prior history of DVT or pulmonary embolism, maybe a JAK inhibitor is not your first or second choice. Don't start that in patients with a well-documented history. The other factors that may play into risk is not just having a prior VTE, but also being elderly and being obese. I would say that for your patients who are well controlled on a JAK inhibitor, and then this information came out, you can inform your patient, but I think there's no reason to stop the well-working JAK inhibitor because of this 1 to 2 to 3 per 1,000 risk, unless the patient wants to stop it. Dan Solomon published the results of the CERT study in methotrexate. This gave us some good information. Mainly, I'm going to point out a few here. As you know, the study was done to prove that methotrexate might be helpful in heart failure patients or heart risk patients. This is not an RA study. And it turns out it was stopped because it didn't work. But they did look at safety in these non-arthritis patients. And they basically showed that there was an increased risk of GI events and pulmonary events. Pneumonitis, 7 cases versus 1 on methotrexate versus placebo. The risk is 0.3% of getting methotrexate pneumonitis. Hematologic events, a very low risk, but still high. Pancytopenia was 3 per 1,000 on placebo and 13 per 100 on methotrexate. And there were 6 cases of cirrhosis noted on methotrexate. And all of those people had abnormalities by labs that we usually would find following the ACR guidelines on methotrexate monitoring. And they were relatively mild elevations of the LFT.
We are well over time, Prof.
Okay, let me end with well, we started late to begin with. Let me end with I want to point you all to looking at the ACR reproductive guidelines. This is a gigantically important paper. I was involved with this. Lisa Samaritano, did a fabulous job putting this together. A few takeaways from this. There's a conditional recommendation that lupus patients who are going to get pregnant be on low-dose aspirin starting in their first trimester. If they have APL syndrome, they're going to be on anticoagulants. There's strong recommendations against the use of cyclosporin and thalidomide in men prior to conception. That makes no sense. But otherwise, men can pretty much take any drug they want and not affect the pregnancy outcome nor the fetus. That includes hydroxychloroquine, Imuran, 6-MP, TNF inhibitors, colchicine, and the ones I have in brackets are all the other drugs which are conditional recommendations. The most important abortifacient or teratogenic drug that we use in rheumatology is mycophenolate. They need to be off it for 6 weeks prior to conception. They cannot take it during pregnancy. And of course, you know that you need to be off methotrexate for 3 months, but actually the package insert says 1 month. So the panel said 1 to 3 months, and you make up your own month. I'll stop there and remind you to register for Room Now. We'll send you an email every day. You can listen to our podcast. Room Now's got its own conference coming up in March. Artie Cavanaugh and I are running that. You can register at roomnow.live. Thank you very much. I'll take some questions if you have time.
Thank you, Prof. And as usual, it's very rich, very wealthy lecture in terms of update. Because of time, I'll leave it only to one question. The first came by order. What is the lowest dose of methotrexate that could stop developing neutralizing antibodies in NTTNF group?
What is the role of that?
Lowest dose of methotrexate. Because sometimes
Yeah, so you need to go back to the original Tiny Mani studies on Rituximab, and they were published in Lancet in 1996 or 97. And the doses that were used in that study, and by the way, it wasn't just methotrexate. I believe it was also sulfasalazine. The dose of methotrexate used was 7.5 milligrams. So you do not need like a high dose of 20 or 25 or even 15. The usual dose of methotrexate, and it was also shown that sulfasalazine has worked. Other studies have shown azathioprine works. So I believe any DMARD therapy has the capability, other than hydroxychloroquine, any DMARD therapy has the capability of blunting an anti-drug antibody response, whether it be for adalimumab or infliximab.
Thank you very much, Prof. Again, I enjoyed this lecture very much. It saved me a lot of reading, as I said. We have the last activity of the day, and you might expect it's about the future, perhaps, in the treatment of rheumatology, which is about biosimilars. I have a pleasure to have Professor Moot here with the symposium run by Amgen, and biosimilar activity is much ahead of us in UK and US. Professor Moot, as you know, he graduated in London, but then he has his experience of, first of all, get PhD in Oxford in immunity in general, and then he had worked in Harvard Medical School in the US and returned back to university with very excellent CV in terms of research, and he got himself head of a rheumatology group in Liverpool and professorship, as well as now he is moved from Liverpool University to Edge Hill University. His interest is chronic inflammatory disease and all research, molecular, biological, and all aspects. And he ran the group in collaboration with Euler activities, and he had numerous publications and chapters and books. And I'm very much welcome him today to give us a bit of inkling of what's going on in the world of biosimilars. The stage is yours, Prof.
Thank you. Thanks very much for your kind invitation. It's really nice to be here at the meeting with you. I'm conscious I'm the last speaker of the whole day, so this is going to be a very simple talk, and I hope it's going to be an educational talk as well. First of all, just to declare any conflicts of interest, as you can see, they're all listed there. And the disclaimer from Amgen. I just want to say also that in my presentation, I'm not advocating the use of any one drug, and it's important to know that I use all sorts of advanced therapies, targeted therapies, biologics, and targeted synthetics. Okay, so let's start. Well, I'm a professor, but I also see patients, and this is a typical waiting room. It's full of patients, and they're all complaining. Now, I hope they're not complaining about me, but they are complaining about all of their aches and pains. And we know as rheumatologists, I don't think we're going to be out of business with musculoskeletal problems. And I see a whole spectrum of problems. On the one hand, fibromyalgia. Do you see patients with fibromyalgia? Well, when I see these people, I try and help them out. I help them out of my clinic as fast as possible, because the type of condition I tend to focus on are the much more serious, inflammatory, damaging, and frankly, life-threatening conditions. And that's how, of course, we need to manage rheumatoid arthritis. So, given the fact that rheumatoid arthritis is such a bad disease, I think I should just confess that as rheumatologists, in the distant past, we have been really bad at managing it. In the distant past, this was the treatment for rheumatoid arthritis. Patients were admitted to hospital, they were put onto bed rest, their joints were put into splints, and that was it. Clearly not a good treatment. And then, of course, we had our great colleagues, the orthopedic surgeons, to help us. And here you can see a typical surgeon. They're saying, first, the good news, technically the operation was a complete success. But as you can see, something went rather drastically wrong with this successful operation. And then what's very important for us to remember is that we started treating patients with drugs and medicines. It says there, I'll give you something to ease the pain. I don't know about you, I would rather have the pain than the drug that's given to ease it. And we have to remember that when we're giving drug treatments, we've got to prevent harm as well as doing good. But of course, rheumatologists today were very different. We're all very handsome, intelligent. It's the best specialty in the whole world. And though I can't see you, I'm hoping that you're all nodding. As rheumatologists together, we know that this is the best specialty. And the type of help we can give our patients is so much better now than it was many years ago. And one of the reasons for that is that we understand the science behind rheumatoid arthritis. Here's a little cartoon. There's a lady, she's crying because she's in pain. She's got a swollen joint. And then when we look inside the joint, we can see a whole variety of things. Angry, inflamed cells, inflammatory cytokines, a whole soup of really nasty inflammation. And of all of these, TNF, tumor necrosis factor alpha, is one of the key cytokines that's underlying that inflammation. So it's not rocket science to think if we can suppress TNF, then we're going to be treating patients. And of course, that's what's happened. The biologic drugs, of which at the moment the TNF blockers are by far the most widely used, are very effective. They work fast. I consider them to be pretty safe. But, and it's an important but, they're very expensive. And that clearly has implications on any healthcare system, whether or not there's reimbursement, whether patients have to buy it on a cash and carry basis, but whatever, these biologic drugs that we use are great, but the cost has been prohibitively high in many cases. So then, quite rightly, we've had the development of biosimilars. And we've been using biosimilars in the UK for many years now. And I think it's exciting that they're starting to become available for you. But first of all, let's just think a bit about what a biosimilar is. Here you can see two people. One of these people is handsome, intelligent, really going places. And the other one is an out-of-work actor who's trying to copy me. Funnily enough, although you probably recognize on the left George Clooney and I share about 99.9% of our DNA. But I hope you'd agree, if you have a rheumatological problem, only one of these two people is going to really help you. So though we're very similar, there are differences, and these differences are very important. And that brings me on to the biosimilar drugs. And biosimilar drugs are effectively very, very clever reverse-engineered copies of the biooriginator. They've been designed so that they're so closely similar, it doesn't matter at all in the clinic. But of course, the truth is that they're not absolutely identical and absolutely similar. And one of the things that's really crucial here is how these drugs are developed, how they're evaluated, and, as I'm going to show a bit later, what real-life experiences of them. So when I think about any drug, there's always two questions that I really need to know. Number one, does it work? And number two, is it safe? These are very standard drugs, very standard questions that we need to know about any drug that we're going to be giving to our patients. But now I would suggest that we add a third. Can we afford it? And the great thing about the biooriginator biologics is that they worked very well. They were really a revolution. Were they safe? Well, nothing's perfectly safe, but I think we're all very confident and comfortable about using biologic drugs. But the problem before was not everybody can afford it. And that's why biosimilars are so crucial, because the hope of the biosimilars are that by having more competition, the price is going to be driven down for a drug. And indeed, we've seen prices for biologics absolutely plummeting because of biosimilars. And that's a really good thing. It allows us to deliver effective drugs to our patients, and perhaps hopefully to even more patients, perhaps those with less disease activity. So this evening, I'm going to be just briefly summarizing some of the evidence for one of the biosimilars. Now, of all the molecules, TNF blockers, adalimumab is the most widely used around the world. And that's because it's very effective, and that's because it's also got a very good safety profile. And there are a number of biosimilars for adalimumab, but tonight I'm just going to focus on Amjevita. I'm going to be talking a little bit about the European guidance on biosimilars, and we've been using biosimilars in Europe for a long time, and I would suggest that the European guidance is a good thing to be basing our practice on. I'm also going to talk about real-world evidence, and I'm going to explain why real-world evidence is crucial. Clinical trials are important, but real-world evidence in this situation is going to be crucial if we're going to be making the right choice for our patients. And as I say, I'm focusing on adalimumab, Amjevita, and rheumatic diseases. So first of all, how do we regulate biosimilars? Well, there are different processes around the world, but the key thing is that you can copy a drug either through the system of regulating a biosimilar that the FDA, EMA, Europe, and a few other places actually do. And that means there's a very high scrutiny to make sure that the biosimilar is sufficiently close to the biooriginator so that there's no measurable difference. In other words, any differences don't matter. And that's very different to some other types of copy drugs, which are called biomimics or follow-on drugs, or things like that. These have not been developed to the same level of rigor, and we can't guarantee that they're sufficiently close to have no significant difference. So in the EU, we have, this is a year or two old now, you can see that there are many reviews of potential biosimilars. Not all of them pass. Some of them get withdrawn. Some of them are turned down because the scrutiny is very high. And as a consequence, there's many biosimilars that are actually available. And actually, some of them that were available have been withdrawn. So this is an area that's fairly fluid, and it's important to know what biosimilars we can really rely on. And again, this slide just shows you over the last few years the various biosimilar developments, and these are all randomized controlled trials that show equivalence between a variety of biosimilars, a variety of companies, and their reference products. So this is a crowded area, and as I showed earlier, some drugs drop out and other drugs move in, but the key thing is that the regulatory process is appropriate. I can't emphasize that enough. So here we have ABP 501, which is Amjevita. As it's going through its regulatory assessment, there are 100 different assays which are measured to actually look at how similar it is to the biooriginator. And this is a very boring slide that we normally never see in medicine, because here we're looking at two different drugs, and what we're looking at is that they're all similar. When we do studies, we tend to try and look for differences. Here, we have to do very detailed studies, but to be a biosimilar and appropriately approved, there's got to be no significant difference. And that's crucial. So on these primary structures, aggregates, particles, thermal force degradation, I'm sure you all know what thermal force degradation is. But whatever, all of these biochemical properties have got to be effectively the same. And also, we can see here that the pharmacokinetics have got to be the same. And you can see in yellow, there's the Amjevita, and in the other two bars, there's adalimumab either synthesized in the US plant or synthesized in the European plant. And the bottom line of this is that, I don't know about you, I can't see any difference. And that's what we need to see, no difference. And then when we start looking at it in patients with rheumatoid arthritis, again, we're looking at trials that are used to actually license the drug. And again, we can see no difference between in kind of yellow-orange Amjevita and in blue, the biooriginator adalimumab. Here we're looking at people achieving an ACR 20, 50, and 70. These two drugs look to me to be exactly the same in the clinical trials. So what have we been thinking about in the various societies in Europe with regards to guidance on biosimilars as these drugs have been coming through? Well, there are two I want to tell you about. First of all, the EULAR position paper. And again, this was published a little while ago. And I just want to highlight a couple of things in this. First of all, if a patient's naive to a biologic, if they're going to be starting a biologic, the idea is that if you have a properly approved biosimilar, you give the less expensive biologic. Of course, in some situations, the biooriginator has dropped to be less expensive than the biosimilar. Not very often, but if that happens, you would go for the biooriginator. So you'd actually go on a cost basis for the one that's the cheapest. I think the second thing, I'm not actually going to be going into this, but it's fine to switch treatment, but do that once. In other words, if you have people stable on a biooriginator, then it's reasonable to switch them to the biosimilar if that drug is significantly less expensive. Of course, you've got to monitor the patient and be prepared to potentially swap them back if there's a problem. And also, our practice is that we would not do that without informing a patient and getting their permission. So we don't really like swapping more than just that once. We certainly do not recommend switching between different biosimilars. And again, there's a variety of reasons, theoretically, why that's not a good idea. But we actually have very little evidence worldwide to know whether that's true. And we also feel that it's important that we, as the physicians, make the choice rather than a pharmacist dispensing whatever is the cheapest drug of the day. Similarly, when we look at the European Crohn's and Colitis Organization, when we're looking at inflammatory bowel disease, where a lot of biologic drugs are used, particularly TNF blockers, you're getting the same type of guidelines. So this is really a consistent approach. And it's very important that we do have position statements as professional bodies as to how we do that. There's been a nice position paper from South America with an interesting consensus process that led to the agreement for that. But as I mentioned earlier, one of the crucial things is what happens in your clinic and my clinic. What happens in the real world? Because for biosimilars, the development process is very much accelerated. The trials that are done are much shorter, fewer patients, and perhaps simpler than the original studies that were done to license the biooriginator drug. And there's a good reason for that. If you expect a drug to be very similar, and if you're doing a non-inferiority study, then you don't need so many people. But I don't know about you, but many people want to know a bit more. And I find that physicians need more evidence for safety and effectiveness of biosimilars. But the randomized controlled trials can't always answer that because, as I mentioned, it's a simple and short study. One of the problems of RCTs is they have very strict inclusion and exclusion criteria. And when we have patients in the real world, they maybe have many more different problems compared to the very tight, limited properties of patients in the trials. And if you do trials, you'll be very familiar with the fact that patients that you see in normal clinics can be very different to the type of patient that's eligible for a clinical trial. So the trials don't represent our patients in the way that perhaps we would like. And also trials are blinded, and that can be a really good thing, but it can run into some problems. So real-world evidence is very important because that gives us the essential information in addition and complementing the clinical trials. In the real world, we can follow patients for several years. We can have our own patients with a diverse patient population in the clinics. We can include additional outcomes, patient-reported outcomes, economics, and all of these kind of extra things, particularly perhaps an economic evaluation, has the potential to differentiate a biosimilar from its competitors. That's a very difficult thing to do that we can maybe talk about later. But there's a potential in the real world as we observe these drugs to know what's going on. So, what I want to do now, is to present a summary of some of the real world evidence for adalimumab biosimilars. So here are 4 studies from a variety of places, Italy and the UK. And we can see here that, again, these are real world at the moment. We're not looking at huge numbers, at least in those years. It's not been long after we've had the biosimilars out then. But we're looking in Italy, 28 patients with psoriatic arthritis, good improvements by week 12. Another case series with psoriasis, again, Amjevita, which I'm focusing on. Patients are doing very well. And then a more recent study from last year, published from a group in the UK. We're now looking at more patients, nearly 300 patients. And these are patients who switched from the reference adalimumab, Humira, to Amjevita. And patients on the whole did really well. But a small number of patients, as we may expect, reported a flare or side effects from the switch. Now, when anybody swaps from one drug to another, we often think about a placebo response where a patient thinks they might do better with a swap. When we think about biosimilars, we get a tendency, theoretically, to the opposite, which is a nocebo effect. So if I swap somebody from a Rolls-Royce car, the biooriginator, the very expensive one, to an old Bangor Fiat or whatever, then patients might think, well, I'm being given a cheap drug, I might not do as well. That's a theoretical risk as we swap, but as I'm going to come to it a little bit later, we don't tend to see it. And then finally on this slide, on the bottom, another study from Italy, patients doing well. You can't really tell any difference between the biooriginator and the Amjevita. Now, at this stage, I want to just throw in something that you might think is a bit strange. And that's not talking about the drug itself, but talking about the excipient. In other words, what the drug is dissolved in. And I've met quite a few years ago, we're looking at 3 years ago, there's a little study which led to pharmacists in the UK suggesting that having citrate in the solution that dissolves the adalimumab might lead to an injection site reaction, whereas if there's no citrate, that's not going to be a problem. And at that stage, they thought that this could be an issue. It's hard to generalize. But as we found in the real world, there is an issue. Now, just very quickly, Amjevita does not have citrate in it. There are some biosimilars that have citrate in it. And also, we have some of the biooriginator Humira, some with citrate and then not with citrate. The bottom line here is that we can see here in the gastroenterology adalimumab 1 and 2, there's a huge number of switches back to the biooriginator in those patients that were swapped to a biosimilar that had citrate in. Just again to show you another slide, Amjevita and psoriatic arthritis, very, very effective. This case series from Italy, highly effective drug in the real world setting, very low rate of adverse events. Now, I always like to look at drug retention when I'm trying to work out if a drug is effective, because patients will stay on a drug if it's working, if it's not causing a side effect, and of course, if it's affordable. When we look at adalimumab biosimilars, and in this case, I'm showing the data for Amjevita, there's no difference in retention rate between the biooriginator and the biosimilar, and that's really encouraging. So just to summarize the switching studies, there's accruing, developing real-world evidence showing that biosimilar adalimumab in Europe is very effective. There's good data for Amjevita being well tolerated in patients both with inflammatory bowel disease or rheumatological diseases. There's good evidence to show that the formulation of biosimilars may impact on the clinical effectiveness. In this situation, if the particular biosimilar has citrate in, that can lead to a higher frequency of injection site reactions. Of course, Amjevita does not have citrate in. And these real-world data are encouraging. They complement the licensing studies, and they're showing us that we can be reassured if we have a good biosimilar, it's going to be as effective and safe as the biooriginator. So just a couple more slides now, just about open label extensions. And I think that's always very important because open label extensions allows us to get a feel for long-term effectiveness. Here we can see here in a study in moderate to severe rheumatoid arthritis, the original study on the left, randomized, and then the open label extension on the right. Again, people that respond, stay responding, that's fine, that's what we would hope for. One final study to show you before I summarize, and that's this a comparative study of Amjevita versus adalimumab in psoriasis. And you can see the study design there. Patients are randomized either to biosimilar or to the biooriginator. And then after 16 weeks, they're re-randomized if they're on the biooriginator, either to stay on the biooriginator or to go to the Amjevita. So what does it show? A good biosimilar, you won't be able to tell the difference. And indeed, over the year, I can't tell which is which from that. So these are behaving in the way that we would expect the biooriginator to receive. Right, so just to wind up, real world experience and evidence on biosimilars, a lot of this is coming from from Europe. It's getting more and more good with regards to numbers, and it's very positive. The results tend to fit, well, do fit with what we find from the randomized controlled trials. And particularly with the adalimumab biosimilars, such as Amjevita, effectiveness and safety indistinguishable, but we've got to be careful that many studies have not been powered to detect differences. There's no particular comparator. And when we look at real world data, it's helpful, it's complementary, but it's not perfect. It's very important to remember that. We found variable discontinuation rates in the real world, sometimes higher than those seen in randomized controlled trials. And I mentioned again about this nocebo effect. We tend not to see the nocebo effect in the UK because we give good explanations to patients. We get their engagement if we're going to be swapping them to a biosimilar, so they know what they're doing. We find a very, very small number of people find that they're reporting a flare or a problem, so have to switch back. And again, when we look at open label studies, that's what we might expect. People do tend to have higher discontinuation rates. So in the UK, because of good patient education, I believe, we don't tend to see a nocebo effect. And if we play things sensibly, we put the patient at the center of things, our experience of biosimilars in the real world is very positive. So now, with our National Health Service in the UK, there is block purchase of biologic drugs on a regional basis where there has to be a contract with the lowest priced one. At the moment, Amjevita is probably the most widely used adalimumab biosimilar in the UK. And we're finding very good experience with this, as indeed we are with other biosimilars, not just for adalimumab, but for other molecules such as etanercept. So look forward to using biosimilars in your practice. We've got a lot of reassurance from our observation in our practice. Thank you for listening.
Thank you very much, Professor Mood, regarding this very nice summary. I am myself Amgevita user and in substantial amount. Although we don't have that cost restriction in UAE, still we are allowed, but we just feel inside us. Sometimes we need to do that. Is someone paying? Why paying more? I moved from rheumatoid arthritis and then started spondyloarthritis. And as you said, the gastroenterologists start to accept, let me say, the switch. Although I usually give it as a first patient, naive patient. Don't go to this nocebo effect, if I can. But my question is, because in our locality, they refer me a lot of uveitis, hidradenitis, and other indications, pages sometimes. When we need someone to tell us, yes, this is okay to do it for all indication. Where are we with that? How do you feel about it?
So, great question. And though lots of studies are done on rheumatoid arthritis, there is the extrapolation of indication. And theoretically, because of the design of the molecule, because of everything else, we should find no difference, even though we only have a license in one indication. On a practical angle, there's very little Behçets in the UK, but I run a national centre for it. And we have no worries about using adalimumab biosimilars for things like uveitis. We find that their effectiveness is just what we would expect from the biooriginator. And we would expect that sort of a thing. So we've been confident in actually prescribing it to those patients, and we haven't found any problems.
Right, excellent. The other thing is about if you start biosimilar in Juvita, can you switch a second one is originator?
So we recommend that if people switch between different variations of the same molecule, it only happens once. So that could be from a biooriginator to a biosimilar, or it could be the other way around. Or of course, if somebody switches whatever way it is, and the switch means that the patient doesn't do well or reports not doing well, then we could switch back to that. But we wouldn't think that for biosimilar A for adalimumab, we'd swap to biosimilar B for adalimumab. And that's a theoretical worry with regards to anti-drug antibodies and other things, which, to be fair, there's no evidence for, but we want to try and keep the risk of that to a minimum.
Right. Now, the third question, perhaps we close it after that. Humirates of adalimumab or infliximab, they are biosimilar themselves in a way through generation. If we have another biosimilar B to Amgevita, let me say is Amgevita, but a new batch or new changes, how we play the game here?
Well, again, that's a great question because, one of the reasons that I showed that the trials, the original trials for biosimilars are done for adalimumab against the US version, synthesized in the US, and the European version. Now, actually, though there may be very small differences there, the quality control that's required by the regulators is so high that if there's significant drift between the same molecule over time, then that's not allowed. And again, for the biosimilar, they have to be run against the manufacturing process in different plants. So most is done to try and ensure, and I think does ensure, that the difference is not significant at all.
Thank you very much for this very nice summary of biosimilars. I'm sure audience will find it very useful. Still, in our territory, not all people tried biosimilar yet, but I'm one of the lucky ones, perhaps. And thank you very much for this insight.
Thank you. Thanks for inviting me.
Take care. See you. Bye-bye.